Okay, I'm Mike Merson. I'm director of the Global Health Institute. I want to welcome all of you. We're going to have a very exciting day discussing some really important issues. What could be more important than advancing the health of women, young people, and children here at home and around the world? I don't have to tell this audience that by investing in the health of women and children, we set entire communities on a course toward health, well-being, and prosperity. I hope you will find, I know you will find our lineup of keynote speakers and panelists inspiring and informative. But let me first thank Kate Wetton for organizing this event, her Center for Health Policy and Inequalities Research, as well as the Sanford School of Public Policy. Who do I thank there? You for both? Kelly Brownell, okay. I just want to mention there's a slight change in the program that Barbara Stillwell, Senior Director of the Health Workforce Solutions at IntraHealth, is going to facilitate our last panel. But really what I first want to do is welcome our provost from Duke, Sally Kornbluth. She also is the Chief Academic Officer. She's going to kick us off today. Sally, for those of you who don't know her, is a gifted scientist who I think still works in cell biology. Advancing knowledge in the mechanism of disease like cancer and degenerative diseases such as amyotrophic lateral sclerosis and Parkinson's disease. Sally was Vice Dean for Basic Science in the medical school from 2006 until she assumed the role of our provost in 2014. She's a member of the Institute of Medicine, a fellow of the American Association for the Advancement of Science. But I think most importantly, she's been a great friend to our institute, to the interdisciplinary approach that we take toward our work. And we're delighted. I know how busy Monday mornings are, Sally, but I'm glad you could come and welcome everyone today. Sally Kornbluth.
Thanks very much, Mike. I'm always happy to come over here because, as I told Mike, although I'm a cell biologist, every time I hear something about global health, I feel like I picked the wrong career path because this always sounds a lot more interesting than some of the work I've done, to tell you the absolute truth. In any case, I'm really delighted to welcome you all here today to a symposium that will examine one of the most important issues facing our communities and our world today, the health of women and children. So I looked at the program, which I think looks terrific, and this agenda will allow all of you to examine the issues related to maternal, adolescent, and child health from a variety of compelling angles, and you'll have the opportunity to hear from an exciting lineup of global figures who will deliver the keynote addresses. Ann Stars from the Guttmacher Institute, Mariam Clayson from the Bill and Melinda Gates Foundation, and Duke's own Gavin Yamey. In between, you'll hear from many of our valued local partners, such as UNC Chapel Hill, IntraHealth, FHI 360, and IPASS. I have to say, I'm really impressed looking at what's going to go on today, looking at the posters around, with the depth of research taking place on maternal and child health issues here at Duke across our schools and disciplines. So today you're going to hear from really people from all sorts of corners of the spectrum, range of the spectrum. Today you're going to hear about a Duke economist about the work she's doing to increase the age of marriage among young women in Bangladesh. We'll hear from an engineer who's developed a device that will deliver cervical cancer screening to community settings in low-resource countries with the potential to save millions of lives. And I remember actually when I first read about this, I thought it was really, really exciting. We'll hear from a public policy expert whose research shatters the myth that the family setting is always the best one for orphans and vulnerable children. And we'll hear today from an expert who is working to address the physical and emotional damage that comes from with a childbirth injury that is all too common in low-income countries. As an academic, and actually as a mother as well, I'm heartened by the important work that's being done by so many of you to improve the health and lives of women, adolescents, and children around the globe. Now, we all know that this is a critical area of work for our communities and indeed for our world, because when women and girls thrive, families and communities prosper. So I hope you have a very exciting conference, and I think I've been leaning on the thing and changing slides, so whoever starts first is going to have to go back. I didn't say that I had technical expertise here, but anyway, I hope you all have a really interesting and wonderful conference today and enjoyable day. So with that, I'll kick you all off. Kick you all.
Anne, are these yours? Oh, good. Okay. Is that your first slide? No? Okay. Well, thank you, Sally. Let me say again that to have her come on a Monday morning at this place is really a sign of our university's commitment to global health and to maternal and child health, and I'm really grateful she could come. I'm now privileged to introduce Ann Stars, the president and CEO of the Guttmacher Institute, and I must say, as an old timer in global health, one of the first names I remember is Guttmacher, and it's really delighted to have you here. I should tell you the most important thing I can tell you about this is that Ann managed to escape the General Assembly. We gave her an excuse to leave once the SDGs were adopted, so we're delighted she could come. I hope all of you know that the Guttmacher Institute could not be more highly respected as an organization working to advance sexual and reproductive health and rights. For those of you who follow the political campaigns, there couldn't be a more important topic right now. The Guttmacher Institute works through a program of research, policy analysis, public education, designed to generate ideas, encourage discourse, and promote sound policy and program development. A simple goal, a tough goal, to ensure the highest standard of sexual and reproductive health for all people everywhere. Anne herself is a leading global expert on maternal health policy and an influential advocate for the health and rights of women and adolescent girls. Prior to coming to the Guttmacher Institute, she was president of Family Care International, an NGO that she helped co-found in 1986 and is dedicated to improving reproductive, maternal, and newborn health through the developing world. She was part of the developed country NGO delegation to the board of the Global Fund to fight AIDS, TB, and malaria, and is a member of the Council on Foreign Relations. Trained in development economics and demography, Anne holds a master's degree from Princeton University's Woodrow Wilson School of Public and International Affairs. Her talk today, her keynote talk, is titled Adding It Up, the Costs and Benefits of Investing in Sexual and Reproductive Health. And we are absolutely thrilled to have you with us today. Welcome to Duke. Are you here to assist? Okay.
Oops. Okay, I'm going to let you get it and take it back to the beginning.
Sure. Thanks a lot.
Great. Thank you.
Yeah, you can use the live if you want.
I'll stand here. Yeah. I do have paper, so I'm going to try and avoid hitting the keyboard unintentionally. Sorry, I want to take us back to the first slide because I wanted to be sure that everybody gets to see the names of the lead authors of the report that I'll be presenting the key findings from today. Sushila Singh, our Vice President for Research, Jackie Derrick, who those of you who've been in this field know her name, and Laurie Ashford. So I'm going to be presenting today some key findings from a report that Guttmacher published in December of 2014. So in our field, it's relatively new, relatively recent. It's called Adding It Up. It's actually the third in a series of reports that Guttmacher has been publishing. The first one was in 2005. And they've all had slightly different scopes, but the most recent report, the one that I'm going to be talking about today, looks at women's needs for sexual and reproductive health services and why that should rank high on the global agenda. The specific interventions that are included in the report are contraception, maternal and newborn health. It also includes care for pregnant women living with HIV and treatment for curable sexually transmitted infections, which is an important and often neglected issue. So the goal of the report is to present comprehensive estimates of the magnitude of need for sexual and reproductive health services, as well as the costs and benefits of addressing those needs. It provides estimates for 149 developing countries and includes a number of different scenarios, current level of services, and then what could be achieved if 100% of women needing care received the services that they need. We also looked at synergies between sexual and reproductive health focus areas and look at the possible benefits of addressing sexual and reproductive health in an integrated way. I know there's going to be a discussion later on integration, so just wanted to mention that. There are 6 other slides in this presentation on data and data sources, which I'm not including, partly for time, or mostly for time. But just very briefly, the estimates that we present use a wide range of data sources. Main ones are national surveys in 119 of the 149 countries, but it's mostly the smaller countries that we don't have national data from. So 90% of women of reproductive age in those 149 countries are covered by the surveys that we used. They include the demographic and health surveys, UNICEF's mixed surveys, CDC surveys, and also we use data from WHO and the UN, in particular for estimating the costs and benefits data. So what are the key findings? I'm going to go through the different elements of the services of the care that we're going to be talking about. So I'm going to start, what are the absolute number of pregnancies, abortions, and births that occur each year in the developing world? And also talk about what are the levels of unmet need for these services. So we see here that there are 190 million pregnancies each year, of which about 2/3, or 125 million, are live births. About 36 million are induced abortions, 26 million are miscarriages, and 2.6 million end in stillbirths. I'm going to start here now talking about pregnancy-related care. So the number and proportions of women who get pregnancy-related care, as you can see from this slide, increased between 2008 and 2014. You can see the increases in the number and the proportion of, the proportions are here, there we go. The number and proportions of women who get antenatal care and the improvements in coverage of institutional delivery, the proportion and number of women who deliver in a health facility. However, we can see from the slides for the bars for 2014 that we still have, in 2014, 43 million women who were not delivering in a health facility and 54 million who were not getting the 4+ recommended visits for antenatal care. A little bit more detail on the antenatal care figure, that the proportion of women who made 4 or more antenatal care visits went from 51%, I'm on the left-hand bar here, to 47%, sorry, to 57% between 2008 and 2014. And this is really a pretty slow rate of increase. It's about 1% per year. We also can see in this slide that there are wide disparities, that fewer than half of the women who give birth in Africa make the recommended number of visits, and it's not much better in Asia. And then towards the right-hand side of the slide, you can see that in the 69 poorest countries, again, only 46% of women were making 4 or more antenatal visits, compared to 82% in the better-off developing countries. This is not the developed world. This is still just the better-off developing countries. Here you can see some progress in antenatal care coverage for specific countries. Rwanda, which is in green, has one of the fastest rates of increases. So you can see that by 2010, about 40% of women were making the recommended number of visits. Bangladesh, which is in that sort of rust color, and Ethiopia have also made steady progress, but at a slower rate than Rwanda. India and Uganda have made very little improvements on this indicator, which is interesting because it's not the case when we get to the skilled birth attendants, as you'll see in a minute. And at the top of the graph, we have the Dominican Republic and Colombia, which have had relatively slow growth, but they had relatively high rates of coverage at the beginning. So one of the other interesting things about this, and we don't delve a lot into the content and quality of care, but we do have this one slide, that even pregnant women who are receiving antenatal care don't necessarily get all of the interventions they need, and the gap, again, is especially large in poorest countries. So in the poorest 69 countries, among women who made at least one antenatal care visit, to a skilled provider in 2012, about 60% received each of two essential tests: the blood test to detect anemia, and a urine test which looks for signs of pregnancy-induced hypertension, while in other developing countries the coverage for these interventions was much higher. Okay, so now I'm turning to the issue of where women give birth. And again, you can see here that substantial gains were achieved in the proportion of women delivering in a health facility between 2008 and 2014, that went from 55% to 66% for the developing world as a whole. Africa had one of the slowest rates of growth and is still at the lowest level of institutional delivery overall. Gains in Asia were quite significant, as you can see, from 55 to 70%. But then again, you can see in the second slide, the second bars from the right, that overall, for the 69 poorest countries, we're still at just over 50% in terms of the institutional coverage. This slide shows the breakdown of coverage by sub-region. So you can see that Eastern and Western Africa have the lowest rates of institutional delivery, and Eastern Asia, Central Asia, South America have the highest rates of coverage. And then here are some country-specific examples. And again, there's wide varieties. You can see the dramatic increase in Rwanda in green. Uganda also, as I hinted at earlier, has made some significant progress in this indicator, unlike its progress on antenatal care. And Ethiopia and Bangladesh have also had some improvements, but are still at an overall low level. And I think this is reflective of those of you who know some of the global frameworks that the Millennium Development Goals had a strong focus within the maternal health goal on promoting skilled attendance at delivery, and a number of countries have adopted policies to try and prioritize and make this happen. Sorry, I'm just going to move that little clicker there. And so we saw that you can see the impact of a strong political commitment to skilled attendance in the growth in some of these specific countries. Okay, so across here we're framing the data slightly differently. We're looking at the percentage of unmet need for institutional delivery. So this is the percentage of women who give birth who do not deliver in a health facility. And it's quite striking here that in Africa, 71% of the poorest women do not deliver in a health facility, compared to 18% of the wealthiest quintile. And the differences are equally large in Asia, where you can see it's 68% for the poorest and 8% for the wealthiest. The inequities are smaller, as you can see in Latin America, but it has, as has been the case historically, and if you look at coverage for child health interventions, particularly, for example, for immunization, these variations by wealth quintile, while they are still there, are significantly smaller in most countries. So survey data provide some insights into why women are not delivering in health facilities. On the supply side, key factors include the cost and distance to a health facility, lack of transportation, and poor quality of care is often an important contributing factor, both poor quality of care from a technical, clinical perspective, but also poor quality of care in terms of interpersonal interactions. And there's been quite a bit of research and work and advocacy work being done on this by a consortium of organizations looking at disrespectful and abusive care. And it's really quite, some of the qualitative data on this, as well as some of the quantitative, is quite shocking. On the demand side, we see that women's belief that it is not customary or necessary to deliver in a health facility is an important reason that women give, or that women cite for not going to deliver in a health facility. Lack of a female provider in many cultures is a factor, and in many cases, the fact is that the woman's not making the decision herself. It's a husband, her mother-in-law, etc., that make the decision about where to deliver. Okay, I'm going to touch quickly now on this issue of pregnant women who are living with HIV and the services that they receive. We see that there are 1.5 million pregnant women living with HIV. and that about 1/4, 26%, that section in green, receive the care that is recommended by WHO, the B+ regimen, which involves lifelong use of antiretrovirals to both protect a woman's health as well as to prevent transmission to her newborn. There's about almost 40%, 38%, receive no care at all, and then the remaining portion, just over a third, receive some antiviral medication, but only during pregnancy and breastfeeding. So it's essentially to prevent transmission from mother to child, but isn't addressing women's needs comprehensively. So we have a very significant gap still. While there's been a lot of progress made on access to HIV treatment, we're still, even for pregnant women who have generally been identified as a priority in many of these programs, not receiving the full care they need. One slide here on sexually transmitted infections. This was a very difficult area to get research on, but the team estimates that there are 204 million women with a curable sexually transmitted infection, and what we looked at was syphilis, gonorrhea, chlamydia, and trichomoniasis. But the vast majority of these, 83%, whether symptomatic or asymptomatic, did not receive the care that they needed. Only 17% who had symptoms actually received care. So in summary, in terms of the maternal and newborn health services, we see that there are millions of women and newborns who still lack essential services in 2014, that there were 43 million women who didn't deliver in a health facility, 21 million who did not receive the care they needed for complications during pregnancy and delivery, 550,000 pregnant women living with HIV who received no treatment to prevent transmission for themselves or to prevent transmission to their newborn, and 33 million newborns who did not receive care for complications. It's a big gap. Okay, I'm going to turn now to contraception. What you see in this slide was that there were impressive gains from 2003 to 2014 in the number of women using contraception, from 510 million to 652 million women. But you also see that the numbers of women who want to avoid pregnancy, who either want to delay a pregnancy by 2 years or do not want to have any more children, that number, the white part of the graph, stayed relatively steady over this period. We were at 210 million in 2003, 220 million in 2008, and we're still at 225 million today. So we still have essentially no real decline in the number of women who have an unmet need for contraception. And it's interesting to look at this and compare it to the relatively significant increase in the proportion of women who are getting institutional delivery. We're not making the same kind of progress on contraception. So this slide breaks it down, again, by wealth quintile and by region. We can see that the proportion of women with an unmet need for contraception is much higher across the board for the poorest quintile, the left-hand orange bar. But these differences between the wealthiest and the poorest quintile are particularly striking in sub-Saharan Africa. And in fact, the overall level of women with unmet need for contraception is, I would say, mind-boggling. That 73% of the poorest women in sub-Saharan Africa who want to avoid a pregnancy are not using an effective method of contraception. And even among the wealthiest, it's still a 46% level of unmet need. So we clearly need to do a lot of work. This slide, it shows, it's, I think, also quite eye-opening. It looks at the reasons for non-use of contraception by region. And there's a fair amount of variation, but it's important here to note that concerns about side effects, opposition from family members, and infrequent or no sexual activity are generally, at least in Africa and Asia, the top 3 reasons that women give for not using contraception. Within our community, it's a standard statement that lack of access to contraception or lack of awareness of the benefits of contraception is a key reason for non-use of contraception. And what this slide shows is that those two factors are in fact negligible in just about every place. They're a little bit more significant in sub-Saharan Africa, but lack of awareness of contraception and lack of access is a relatively minor factor. So it's not about just promoting, making people aware of contraception. It's really about understanding what is behind unmet need. Why are women and their husbands or partners choosing not to use contraception, and what can we do about that? So this graph is an interesting one. Shows that of the 1.6 billion women of reproductive age in the developing world, that about 57% are in need of a modern, effective contraceptive, i.e. they want to avoid pregnancy. On the left-hand chart, you can see that 21%, the orange part, want to postpone the next birth by at least 2 years, and 36% want to stop childbearing altogether. So that's the total of 57%. So that 57% of women who want to avoid pregnancy is, the number's 877 million, which takes us to the right-hand pie chart. And you'll see that of that 877 million women who want to avoid pregnancy, that about 74% are in fact using contraception, but there are 225 million women, 26%, who are not using contraception. That 225 million figure that I've cited a couple of times here is it's kind of the headline figure from the Adding It Up report, which is, well, I'll talk about that a little bit more towards the end when we get to the policy implications, but it's, you see it crop up a lot. So if this slide is now looking just at that 877 million women, and you see that the 26% of the 877 million women who want to avoid pregnancy, that 225, who are not using contraception, account for 81% of unintended pregnancies, which makes sense. Clearly, the women who are using contraception, we know that contraceptives do fail, so even women who are using contraception do experience unintended pregnancies, but clearly, it's much greater among the women who are not using contraception. Okay, I'm going to turn now to the costs and benefits. And this is a slightly complicated slide, so I'm going to spend a couple of minutes on it. Our team looked at the costs of current provision of care and here we're looking at contraceptive services and maternal and newborn care. So currently, left-hand bar, you can see we're spending $4.1 billion on contraceptive care and just over $14 billion on maternal and newborn health. And we've split the maternal and newborn health into costs for intended pregnancies and costs for unintended pregnancies. The middle column shows what the cost would be if we expanded maternal and newborn health services to fully meet needs. And that means both in terms of the number of women who are not receiving care, who should be receiving care, but also providing the full range of quality, addressing the full range of quality gaps. So you can see that the cost rises substantially to $40 billion overall. The third column, interestingly, looks at what the cost would be if we expanded contraceptive services to address unmet need. So the cost of contraceptive services would go from $4.1 billion to $9.4 billion, significant increase, more than doubling. But because the use of contraceptive services would then prevent a significant portion of unintended pregnancies, the white part of the bar, the cost of providing maternal and newborn health services for those unintended pregnancies, shrinks considerably, and the overall cost of addressing the unmet need for contraception, maternal, and newborn health care would decline. Oh, forgot about those arrows. Overall, what that means is there are significant cost savings from investing in contraceptive services, that every additional dollar spent on contraception would save about $1.50 in the cost of providing pregnancy-related care and newborn care. This is the total cost figures, so it varies a little bit from the previous graph in that it also includes the costs of the treatment for women, pregnant women living with HIV and the STIs as well as the abortion-related care. So you can see from this that the big chunk of the cost of these services is for maternal and newborn care, and contraception is the second largest. And this is a big number, that $39 billion, but it translates into an average annual cost of $25 per woman in the developing world. And in fact, even importantly, we're already spending about half of this. Current costs or current expenditures for this range of sexual and reproductive health services is about $13 per woman. Sorry, it's about $12 per woman, so the additional funds needed are about $13 per woman. And that may sound like a lot, but in fact, per capita health expenditures for the developing world as a whole is about $270. So it's really not a huge proportionate increase in terms of what we're currently spending, and the benefits are significant. If all of those 225 million women with an unmet need for contraception were getting services, then each year there would be, as you can see here, 24 million fewer abortions, 15 million of which are unsafe. There would be 21 million fewer unplanned births and significantly fewer stillbirths and miscarriages as well. If we look at the impact of providing the HIV treatment for pregnant women living with HIV, then the number of newborns infected through maternal to child transmission would decline by 90% compared to what it would be if there weren't any services. So a reduction from nearly 500,000 to about 57,000 women. If we look at the impact on maternal survival, if the needs for both contraceptive care and pregnancy-related care were met, then the number of women dying each year from pregnancy-related causes would drop from 290,000 to 96,000 per year, a 67% reduction. Meeting these needs would reduce the number of newborn deaths significantly as well, from 2.9 million to 660,000, a decline of 77%. So fully meeting the needs for contraception, maternal newborn health provides, as you can see, significant health benefits. Here we use the DALY figure, and I'm actually, in the interest of time, not going to go into this, but you can see basically that meeting the family planning and maternal newborn service needs averts a significant proportion of the disability-adjusted life years. Does this crowd all know what DALYs are? Gavin can fill you in. And that the impact is particularly strong on the lower and middle-income countries. So the benefits of the investing in these sexual and reproductive health services, I've showed what the numbers are in terms of cost benefits, in terms of the health impact. We haven't quantified these broader benefits, but it's important to at least recognize that there are significant broader and longer term benefits to women and their families of meeting these needs for services. Benefits include increases in women's education and earning, increases in household productivity and assets, and increases in children's schooling, and ultimately increases in GDP and reductions in poverty. There have been some attempts to try and put numbers behind this, and I'm actually pushing the Guttmacher team to try and do this, but there's an enormous amount of assumptions that need to be made in order to do this, so they're chewing on it, let me put it that way. So what are the key conclusions that we draw from this? First, you got a sneak preview of this slide earlier. First, you can see that there has been substantial progress in the past decade or so in coverage of some of these key services, but that there are still enormous gaps that remain, that there are enormous benefits that would result from investing in these services, including reductions in mortality, healthier women and newborns, fewer unsafe abortions, and fewer unplanned births, and that there are a range of longer-term social and economic benefits for women, their families, and their communities. So we consider, oh, I forgot, did I leave out the Best Buy? I left out the Best Buy slide, but we have a slide that shows that, that the investment in these are considered broadly a Best Buy. I'm not actually quite done. I just wanted, while this presentation is focused very much on the data, as is appropriate for the Guttmacher Institute, but I know that the title of this symposium is about moving from evidence to policy. So I wanted to just say a few words about the policy implications and the use of this data. The Guttmacher is a research institution at heart, but as Michael said, we also work on the policy and advocacy agenda. And one of the hallmarks of our work is that our research is very much focused on topics that have policy and program implications. So while the researchers are meticulous and uncompromising about the accuracy of the data, we also spend a significant amount of time chewing over the data, figuring out how to present it, how to show it for maximum impact, and also thinking about how to get it to key policymakers and how to distill it into key messages that will resonate. And I have to tell you, sometimes there's close to having blood on the walls or blood on the floor when the research team that have spent 2 or 3 or sometimes 5 years on a product, it goes down the hall to the communications team and they're distilling it into 3 bullets and a half-page infographic, and the researchers are just, no. But it is those infographics and it is those 3 bullet points that resonate. And I mentioned earlier this 225 million women with unmet need for contraception. This report was released on December 4th. We had a launch event hosted by Richard Horton from The Lancet in London. And all of the colleague organizations that work in our space, all the cooperating agencies that and Gender Health and Pathfinder and so forth, all of their year-end appeals for donations all started with that 225 million figure, without attribution, but that's okay. I have out in the back, I have a couple of copies of the Adding It Up report if they're still there. There's also a one-page, front and back of a page summary. We also, again, with that policy audience in mind, we've done summaries in French and Spanish for different regions. And a couple of other just examples of how the data have been used. The previous Adding It Up report, we did a smaller version of the Adding It Up report focusing just on contraception that was released in 2012 in time for the Family Planning Summit that was held in July of that year. And the unmet figure that we came out with at that time was fundamental to almost all of the advocacy communication around the Family Planning Summit, and from colleagues at DFID, at the UK government, and many other places, was highly influential in mobilizing donor commitments. We do a simplified version of this analysis of, in particular, the benefits of investing in reproductive health and maternal and newborn health for USAID, focusing on the USAID supported countries, and that is used very much by advocates during the appropriations process in Washington. I'm not sure how much members of Congress really listen, but at least the data are used. And we do also have the capacity to run these numbers for different subgroups of countries. So with the Global Financing Facility or the Family Planning 2020 initiative, we frequently get asked by donors and other partners to run these numbers for subsets of countries. So I will stop there. Oh, the last thing I wanted to say is I know that adolescent health is part of the agenda here, and I haven't touched on adolescents specifically in this presentation. We are, in fact, working on an adolescent version of Adding It Up, which we will be releasing in May of next year at the Women Deliver Conference in Copenhagen. So I have some data on adolescents that I could share. It's obviously a hugely important population. Doesn't account for a huge portion of the mortality and morbidity, but of course adolescents are critically important in terms of the rates of unmet need among sexually active adolescents are higher than in any other age group. So they have important needs now and are also, of course, critically important in terms of an investment in the future. So I'll leave it at that for now, and I know there's a discussion later today. And the last slide is just to thank those who have supported this work, which is I don't know why it's UK Aid for the British People. I always know them as the Department for International Development. But anyway, so that's DFID, the Bill and Melinda Gates Foundation, and UNFPA were the key partners in this. So thank you. Sure, happy to.
We have a few minutes for penetrating questions. Just state who you are, where you're from.
So I've seen some of the labor and delivery boards in some of these places, and I have to say that I probably wouldn't really want to deliver in some of them. So as you talk about the cost and the scaling up, what can be done, and what is the cost of actually making those labor and delivery places a place where it's safe to deliver and where it's actually desirable?
Let's see if I can do this quickly. The cost figures on the maternal, this slide, that expanded maternal newborn health care costs in the middle. The reason, part of the reason there's that huge jump from the, whatever the figure is, 14 billion to what's 40 minus 4, 36 billion for the maternal and newborn health care is not just because of the number of women who have unmet need, it's also because we calculated what the cost would be of providing, basically meeting WHO standards for provision of maternal newborn health. So it's the supplies, it's the training, it's the salary costs, et cetera, et cetera. So this is, you could argue about what those standards should be, and as I'm sure you've seen that the gaps are huge, but that cost figure is factored in here of addressing quality.
Yeah, hi, I'm Karen Blythe from Health International. Just wondering, did you calculate in your the 2014 US dollars PEPFAR funding? Now that PEPFAR, all those HIV/AIDS, all of that has some components.
Yes, it is included there.
Valuable for us to be able to kind of understand what the need is and what the targets are. I was wondering if you could just speak about your sort of observations and interactions with regards to the Sustainable Development Goals and sexual and reproductive health on the agenda, missed opportunities to be on the agenda.
You're in academia, you can be
How much time do you have?
You can be honest. Say what you think.
Okay. So I'm going to preface this with a slight detour. I've been at Guttmacher for just over a year. I started there in August of last year, August of 2014. And before that, I was at this other organization, Family Care International, which was primarily an advocacy organization. So we've been working, I've personally, in both Family Care and Guttmacher, have been working on the Sustainable Development Goals for a couple of years, at least. The Sustainable Development Goals that were adopted this past weekend at the UN are starting off in a better place than we started in 2000 with the Millennium Development Goals. The Millennium Development Goals, and I don't know how much of you know about this stuff, but the Millennium Development Goals included 3 health-related goals, one on reducing child mortality, one on improving maternal health, and one on combating AIDS, TB, and malaria. There was no reference to reproductive health anywhere in the MDGs when they were first, or family planning, when they were first adopted. The reproductive health and rights community fought a long and tireless campaign to get a universal access to reproductive health target added to the Millennium Development Goals under the improved maternal health goal in 2000. That was finally adopted in 2000, formally adopted in 2007. The Sustainable Development Goals include 2 targets that reference reproductive health. So there's 17 goals overall. There's 169 targets. It's a much more comprehensive view of development writ large, touches on issues around climate change, partnership, a whole range of issues. There's only 1 goal for health this time, but there's a number of targets underneath it. The target 3.7 includes essentially the universal access to sexual and reproductive health services, including family planning. And then there's also a target under the gender equality goal, which is goal 5, so it's target 5.7, that in addition references reproductive rights. So it's a good basis for moving forward. You will note that neither target actually uses the full phrase sexual and reproductive health and rights, because the UN doesn't like the term sexual rights. And so even by implication, they don't allow the sexual reproductive health rights, those 4 words, to be used altogether. The key, so the SDGs were adopted, as I said, this past weekend. The key factor, again, for those of you working in measurement and working in policy know, the key factor that's going to determine what actually happens is what are going to be the indicators that are selected. And that process is still ongoing. The Statistical Commission will meet in March of next year and will adopt the actual indicators that relate to the SDGs. So broadly define what's going to be a monitoring framework. It's unclear how many indicators are going to be adopted. There is some discussion about limiting the number of indicators to 100, which means we'd have fewer indicators than we have targets, which would be an interesting challenge. The general wisdom, but you can never tell with the UN, is that there will be 2 indicators per target. The community, the reproductive health community, has been working for some time, and USAID was a key player in this, in articulating this met demand for family planning indicator. Indicators that have been used for reproductive health for many years have tended to be contraceptive prevalence rate, total fertility rate, are generally the 2 key indicators. I think this met demand for family planning indicator is far preferred, because the problem with total fertility rate or contraceptive prevalence rate is what's your target? What are you saying that the TFR should be 2.1, that women should be having only 2 children? Are you saying that there should be whatever 65, 70, 80% contraceptive prevalence rate? It's imposing a target from a policy perspective without taking into account women's and families' preferences. So what's nice about the MET demand indicator is that the way it's defined, it's the proportion of women who don't want to have a child who are using an effective method, a modern method of contraception. So the basis of it is some indication of women's desires around fertility. That has been the number 1, the top of the list indicator for the SDGs for some time. There's a little bit of a kerfluffle going on right now, because there's some suggestion around shifting to another indicator as the top indicator, which would be proportion of health facilities that offer an essential package of SRH services, which is a nice indicator, and in some ways would be very beneficial, because it clearly is then pushing countries to invest in the provision of services. My concern about it is, my concerns are twofold. One is that we don't have baseline data. UNFPA, or at least some of the folks at UNFPA who are pushing for this indicator, said we can calculate a baseline for this for 8 countries right now, based on the DHS service provision assessments. So that's one concern. My other concern is that it's not a coverage indicator. It's telling us what proportion of health facilities are offering these services, but it's not telling us anything about who's using them and whether women are actually getting the care they need. So while the MET demand for family planning indicator is only focusing on one component of reproductive health, I still think it's critical to have a coverage indicator in there for the SDGs. So that's what we're going to be working for. Guttmacher has produced a recommendations document. I think I even have it with me, but you can find it on our website, maybe. It might be a little hard to find, but you can take a look around on recommended sexual and reproductive health indicators. We've produced a much longer list. I think we have 16 or 13. I can't remember how many indicators we have overall for sexual and reproductive health. We know that there won't be 13 or 16 or whatever indicators for this, but there's the question of what indicators will be adopted at the global level. There's also the question of what countries will choose to hold themselves accountable for. And so we've provided a broader set of indicators there. And one of the indicators that we've included on that list is availability of safe abortion indicator.
We're going to have to stop. Let me say first, Ann, that your data is, well, first, thank you for coming. I know how busy it is for you now. Secondly, your data is very powerful. I could see the audience and We need to all get this data to our students and to the future leaders in global health. This is a long battle. And I guess third, I would say don't stop fighting. I'm sure when you turn on your morning television or watch the Sunday programs, it could get depressing, but don't let that bother you, please. I'm sure everybody in this room wants you to keep fighting for the health of women around the world. So thanks for coming.
Thank you.
So we're just going to take 1 second to get our panel organized. Don't go anywhere.
I think I'm actually introducing the panel, so I'm just going to stay here. Is that okay?
Organized.
Okay, got it. Perfect.
Thank you.
So while the panel's coming up, I'm gonna blab,
Okay.
if that's okay, because just to touch, because about 50% of Guttmacher's work is domestic, and so we have been very embroiled in the current and long-standing battles around sexual and reproductive health in Congress. And one of the interesting things, I think it was last weekend, the Washington Examiner, which is a fairly conservative newspaper, came out with an article that talked about the fact that both the pro-choice and the anti-abortion communities use Guttmacher data on abortion. The antis are actually trying to get a research institute started to do research on abortion, but they basically said, yeah, we use the Guttmacher data because it's really good. And they of course spin it their own way when they present it, but as they said, the abortion providers aren't going to give us their data, as they shouldn't. Oh yes, we should get the new.
And then clicker, you just hit the next whenever you're up here.
Okay, so I'm going to do introductions, and then hopefully we'll have a little bit of time for Q&A after the panel as well. So thanks, ladies, for joining us here today. I think I'll just do the presentations one by one, if that's okay, because I know when people introduce the whole panel at the beginning, I can never remember the information by the time we get to the third or fourth. So our first presenter is Eve Puffer, who's assistant professor at Department of Psychology and Neuroscience at Duke Global Health Institute. She's a licensed clinical psychologist, and her research focuses on developing and evaluating integrated community-based interventions to promote child mental health, improve family functioning, and prevent HIV risk behavior in low and middle-income countries.
Thank you, Anne, and it's great to be here today. What I would like to talk about today are strategies for addressing adolescent mental health and HIV risk simultaneously, using family-based approaches. So I bet everyone in this room is constantly aware that a child's development is not just influenced by the innate characteristics that they bring to the table, but by the systems that surround them. And I think the family is an important system to consider because those relationships, or the lack of those relationships, can be almost a constant stressor or a source of support. Family is important to think about with HIV risk and mental health because if you look at the risk factors for both of those outcomes, they have an overlap with strong risk factors at the family level. We know that sexual risk behavior and mental health symptoms often emerge together during adolescence. And if we know that negative family environment is a risk factor for both, then it follows that improving family processes targets both of those outcomes at the same time. What do we mean when we talk about family-level risk and protective factors? We mean household organization. So we mean, do the people in the family know what their roles are? Do they agree on them? And do they have routines that meet the needs of the members of that family? We mean family dynamics. How do people communicate? What kind of time do they spend together? Is there favoritism or discrimination in those households that's disrupting relationships? Parent-child dyadic relationships. How are parents stimulating their children, managing their behavior, and communicating? And we mean parent-parent relationships, marital satisfaction, conflict resolution, problem solving, and how those parents work together to take care of their kids. So I'll talk about two programs today. Both have targets of family functioning, adolescent mental health, and risk behavior, but take two different approaches. Universal prevention, which targets all families, and then an intervention approach that targets families with current distress. First, universal prevention. I'll talk about a program that aimed to strengthen all families in a general population, but in a high-risk context. In this community, it was high rates of HIV and poverty. And the focus is on reducing risk for future mental health and HIV risk-related behavior. This program is called READY, Resilience, Education, and Skill Development for Youth and Families, quite a mouthful. But we implemented this program in Uhuru Bay, Kenya. You'll see there's sort of a consequence of Mac to PC transition here. We developed this intervention with a participatory approach with close collaboration with a community advisory committee with the goal of taking evidence-based strategies that you all know about from effective programs and combining that with culturally anchored material provided by the local community. READY is a group-based intervention with multiple families together, and it's delivered with religious congregations. In this community and in many others, religious congregations are stable social structures that many families participate in, one of the few places that they actually attend together. And this also includes church leader discussion groups. These are an outline of the 9 sessions. The first on economic communication, emotional support, HIV prevention, with family communication practice in the sessions being an overall emphasis in each session. This is one of the churches where we work. We conducted a randomized trial of READY, and you'll see in bold the outcomes that were effective treatment effects. Our primary outcome was family communication across all domains because we think that's what one important predictor is for future risk. Self-efficacy, and then among the adolescents who reported sexual behavior, increased use of protection and decreased multiple partners in the intervention group, and some improvement of male caregiver involvement. At the community level, the intervention group reported seeking more support from their churches. What READY and other programs like this do not do is meet the need of very highly distressed families. Families that need tailored interventions to specific problems that are intensive enough to actually address those ingrained and complex interaction patterns, and interventions that are private, safe, and self-paced. This recognition, partly through the READY trial, led to our development of a therapeutic family intervention with our colleagues in Kenya. This is for highly distressed families who also have an adolescent in the home with emotional or behavioral symptoms. This program, Tuko Pamoja, or We Are Together, is an individualized family intervention that's delivered by community-based natural counselors. And by natural counselors, we mean the people that families are already seeking out to provide family advising and support. They're spending hours on this per week. This is adapted from evidence-based practice, so from family systems and solution-focused family therapies primarily, with those strategies simplified and structured, but importantly retaining the flexibility that we need to fit existing natural counseling practices. The sessions are tailored to match specific family needs, and we also include a mobile phone-based application. These are the modules that can be matched to the family needs. They relate to building a stronger marriage, building an organized family, stronger parent-adolescent relationships, and then the last 2 are related to developing family support systems for adolescent with more severe mental health symptoms and also caregiver stress. So there are 10 steps that are core to the Tuko Pamoja intervention, and then those 10 steps are applied to these different content modules. So we've recently begun a pilot study of Tuko Pamoja. We've trained 6 of these natural counselors recruited from communities. We've developed a tiered supervision system, which includes counselors, university students who are studying psychology, and clinical psychologists. And we've recruited our first round of 8 families and hope to enroll 24 to 30 over the next several months. This is funded by Grand Challenges Canada with my Kenyan co-PI. Data collection includes fidelity and acceptability data, as well as feasibility. And we're looking at pre-post levels of family functioning and the adolescent outcomes. So just very, very early observations. Fidelity to this treatment varies a lot by the counselor's pre-existing interaction style with families. Most families are prioritizing marital relationship goals, so we present the modules of the program and have families work with us to choose what they want to work on first, and I've been a bit surprised to see the prioritization of marriage. Counselors prioritize recruiting families affected by substance use, which is a function of them being asked to approach families who they would already approach regardless of this program. Counselors are also quickly memorizing the 10-step structure, including those with low literacy levels that were not able to engage as fully with the written training material during our formal training, which was one major concern. So we look forward to more findings that we can share over the coming months. I'll stop there and just acknowledge the organizations that I work with, our research teams in Mahuru and in Eldoret, the natural counselors, and then those who have funded this research. Thank you.
I'll be working my way down the chairs. Okay, I think what we'll do is have all the panelists, and then we'll open it up for Q&A. So our next speaker is Tricia Petruni. She's a technical advisor for global health, population, and nutrition at FHI 360, and as a member of the research utilization team since 2007, her technical focus is on advancing integrated multi-sector approaches, including linking family planning with other development programs. Tricia.
Thank you. Hi, good morning, everyone. Outside of the US, everyone usually says good morning back. Okay. There we go. Thank you. Okay. So as Anne said, I'm a technical advisor at FHI 360. I work in our global health, population, and nutrition group. I sit on a team called Research Utilization, which is why we were excited about the title of this meeting today, because our whole mandate is moving knowledge and research and evidence into policy and practice. So today I'm going to talk a little bit about integration. The theme of this panel is thinking beyond the individual from the perspective of family planning. So how many people in the room know the Indian parable about the blind men and the elephant? Okay, good. I thought you might be a little bit familiar with it, so that's good. I've chosen it as what I think is the perfect metaphor for something we really struggle with a lot in global health and development, which is seeing the big picture. So the story goes that if you blindfold 6 people, I like to say people even though it's men in the story, but I would do 3 men and 3 women. So you put them in a room with an elephant, and you try to get them to figure out what's going on. What are we looking at here? What are we dealing with? And all of them, of course, are going to come up with a different answer because it's so big and all the parts are so diverse, they're not able to actually take it all in. So I think we do this a lot in development where we become really over-specialized and we get really deep down into things so far that we have a hard time kind of coming back out and seeing the bigger problem that we initially started working on. So at FHI 360, last year, we got a $4 million grant from our own foundation, and we started something called the Integrated Development Initiative to, in other words, sort of try to see the elephant. So we're investing resources in sort of learning about multi-sector approaches and things that are really complex, and how can we get people across different technical areas to work together. So as part of this, my favorite thematic issue is how family planning is related to what most people are working on no matter what it is. So let me try to make that case for you. So what does it look like when you take your sort of blinders off and think about what role sexual and reproductive health, and in particular family planning, has in the world, so on women and their families and communities, again, going beyond the individual. And Anne set the stage nicely for us this morning in talking about a lot of the very clear benefits we know come from family planning that are related to women's health, but I want to take the argument a little bit further, making the case for some folks who, right or wrong, aren't going to necessarily prioritize women's health, and we need to make the case to them in a different way. So what most people will start to talk about when they think about family planning's benefits are things like this, and Anne went into nicer detail this morning about it. So of course it improves maternal health and reproductive health in really important ways for individual women, which is fantastic. What some people, fewer will tell you, but a lot of people might actually then take it one step further and say, and actually it helps, young adolescent girls stay in school because it prevents unintended pregnancies, and it also actually can decrease overall family sizes, so there's fewer siblings for that young girl who might have otherwise had to stay home to take care of them. It allows adult women to enter the workforce when they're planning and spacing their pregnancies as they want, and then their earnings increase over time, and we have nice data showing that women invest that money back in their families actually more than men do. So most people would generally stop there, but it does keep going. There's a couple more layers I want to show you. In places where there's in particular sort of really high fertility rates, really high unmet need for family planning, and women are, in general, women and their partners are having more children than they wanted to, better meeting the global demand for contraception can reduce rapid population. And when you do that, what then happens is the demand on sort of important resources like food and the environment are also, the pressure put on those by rapid population growth is decreased. So now we've gone beyond the household actually out into communities and regions and countries. But it doesn't stop there, so it gets better. What a handful of people might actually point out is that meeting global demand for contraception can actually have very serious positive economic growth returns. So there was a really nice paper that just came out last month, actually, from the Lancet Commission on Women and Health that showed modeling data that if we did a better job at meeting the current demand for contraception in 27 high fertility countries, the returns on that would exceed 8% of global GDP growth by 2035. So I think that's pretty crazy. I think more people should know about that, and I think ministers of finance should be picking up their ears and paying attention to that. So what happens when you put all of these things together, right, is you start getting to the elephant. So now, we've looked at very separate things, but then you put them all in a big picture, and it seems to be making the case that family planning is a really good investment. So it empowers individual women in terms of their reproductive health in the short term, but by doing that then collectively and over time, it makes communities, regions, and entire countries healthier and wealthier. So sometimes in this field, we always think that we're talking about over there, and I'm not just talking about places over there. This is very important to all women. It doesn't matter what country you live in. In 2011, the Guttmacher Institute asked a large number of American women, what has family planning meant to you in your life? And the answers they give are not, well, it reduced the maternal mortality rate and things like that. They say, no, look, this changed my life. It allowed me to stay in school, to get a job, to plan my family, and it helped me better support my family. So if you don't want to just take my word for it, or even the Guttmachers, which would be unwise, you should take their word for it, you might be persuaded by the economists who, at the turn of the century, in the year 2000, they said that the contraceptive pill was the greatest scientific advance of the 20th century, which is bananas when you think about how many things happened in the 20th century. You're like, wait, but there were smartphones and all of these things. But I think they acknowledged it with that because for the first time in human history, women had an easy-to-use and effective way to decide how many children they wanted and when they wanted to have them. And the economists said, look, this revolutionized families in developed countries, the workforces, and those countries overall, and with greater political will, it could do the same for poorer countries. So I don't have a lot of time to go into these. I wanted to include them in case people had access to the presentations later, but I did just want to tip a hat to a couple of the things about that moving this information into evidence and or into policy and practice, because on our research utilization team, we synthesize a lot of evidence, but we always ask, so what? What do you want me to do with that information? What should people be doing differently? So 3 quick things. One is advocacy. I think more people should know about these very tremendous ripple effects of family planning outside of the women's health issues, so we need to do more advocacy to non-health stakeholders. We also need to work together across sectors at high levels of policy and decision-making on how interrelated all of these issues are. There was a really nice article came out last week in the BMJ that I've read 3 times. It's really good, so you should read it, where staff from 5 UN agencies and NORAD came together to say, we think we need to be doing a better job at this internally at the UN, but we're also calling for the world to do a better job too. So to come together, get out of a family planning silo and work on these things more broadly. And then finally, some of this is just about doing regular family planning work and its ripple effects and benefits, but there's also an opportunity to really integrate family planning into other areas of work. And we have some cool data coming out on sort of how and where you might want to do that most effectively. So, literal program changes on the ground, adding family planning to other programs that have access to women who need it. So some in health, like immunization and nutrition, and then some totally outside of health, like microfinance and environmental conservation, which is really great. So thank you for listening. Most of the data points I didn't cite individually. They came from these two articles and a couple other things, and I would recommend looking up the Women in Health Commission from the Lancet that just came out. So thank you.
Many thanks, Tricia. That was a great presentation. Okay, our third panelist is Molly Cannon. She's, oh dear. Wow. We're a little tight here. You know what? Let's move the table.
Oh, no, I'm fine. I was just moving the chair so she could get up.
It's a little tight up here, as you can tell. Okay, so Molly is the deputy team leader at the Measure Evaluation Senior M&E Specialist at Palladium. She has provided technical assistance in program planning and evaluation throughout Asia, Africa, and the United States. She's conducted studies related to public health systems in specific public health areas, such as HIV and maternal and child health. And over to Molly.
Thank you. And Karen O'Donnell and I have actually worked quite closely together, and I was not trying to take her out, I swear. We've always collaborated really well together on the Child Status Index and other things, so sorry. I also just wanted to quickly point out that I do work for Palladium, which is formerly Futures Group, so I'm sure many people might have been familiar with Futures Group, and we changed names about a month and a half ago. So I'm here today to talk about integration of community-based services, specifically related to a project we were asked to assess in Mozambique. And so the title of my talk is, It Seems Like a Good Idea, but How Do You Really Make It Work? So I want to start with just a basic story, a family in Mozambique that probably represents many different types of families that we work with in sub-Saharan Africa or other high prevalence HIV countries. So let's say this mother, for example, has HIV and also has transmitted it to her baby. And so just by the sheer nature of that, they need access to ARVs, ensuring PMTCT, and being linked to clinical services and other types of support that they need in their home. Let's say the girl on the left in the green is an adopted niece because her parents may have died from HIV/AIDS and this family has taken them in. And then also on the right is the biological child of the mother and the father sitting there. And she's doing well in general, but is at risk of HIV and other types of problems in her community because of what she's dealing with at the community and also in her own home. And the father is a truck driver who travels quite a bit outside of his home and isn't there to help provide care and support as well. So I just want to give a context of the type of people we're talking about. And so these types of families have many different types of support services that they need right at home in the community. So I'm going to talk a lot about PEPFAR-supported community-based programming because that's what I work quite a bit on. So on the left here, you can see a model of what a home-based care looks like. And this is actually from Tanzania, but it's similar also in Mozambique. And this often falls under the Ministry of Health and is part of a larger continuum of care of services. So typically when someone is tested as HIV positive, they would then be referred for treatment into a facility. But again, this is where the community piece kicks in for that family. So there's home visitors who live and reside right in the same community who go and visit the household sometimes on a weekly basis. It may be a monthly basis. It depends on what the needs of the people are and at what stage of the illness they're in. They may be providing referrals. They may be helping them follow up on their medications. They may be helping clean the house and bathing or providing palliative care types of support and services. On the right represents another type of PEPFAR community-based programming, and this model here comes from the PEPFAR 2012 Orphan and Vulnerable Children Guidance. And this is, in Mozambique, it falls under a different ministry, and that's important. This is the Ministry of Women's Action and Social Women's Affairs and Social Action. And so what orphan and vulnerable children programs try to do is really help support the children in the households by building the resilience of families and communities to help provide and care for those children. And it's general well-being. So it could be providing psychosocial support to that daughter, for example, who might be struggling, helping kids stay in school, ensuring that those children are protected and have access to the resources that they need. So I want to take it down even further to a community view. So you can see in this box, and forgive me, I didn't put in all the arrows and things that could be in there in the interest of time, but you have a community-based organization. These are often faith-based organizations or other types of CBOs. And they are the ones who work directly with those home visitors who go house to house to provide support. So in the red box, you can see the little person. Let's say that's an orphan and vulnerable children volunteer. And so that person would typically go and visit households where there are OVC living in the houses. In the blue box might be an HBC volunteer. And this is how it was working in many places in Mozambique. And they were going to visit households where there were people living with HIV. So blue and red makes purple. At least that's what I remember. So the purple households, for example, are where you might have both home visitors going to take a visit, right, at different points in time. The blue boxes might be households that only have people living with HIV, and the red might be households only with OVC. So what this program did in Mozambique is they said, wouldn't it make sense to just get rid of one of those volunteers and have one cadre of volunteers who provide services to both households with people living with HIV and OVC. Makes sense, right? It's less invasive for the household. You can really capitalize on, the relationships with the health facility, take care of what the household needs are at the same time. So USAID, Mozambique asked Measure Evaluation, and I was the activity lead and PI for this, to take a look at what was happening because a lot of the funds were coming from OVC. And so what they really wanted to understand is, well, what does this integration really look like for the children in these homes? Is it providing them with the same amount of services, better services, worse services? Unfortunately, we couldn't do an impact evaluation because the project had already rolled out in 49 of 52 districts. So what we did do is say, okay, well, let's do a cross-sectional mixed method study with the amount of money that they have and talk to a lot of the different volunteers who are on the ground. Let's go to households and try to figure out what's happening for them and the types of support and care they're receiving. And we did a series of national level and subnational interviews and focus group discussions. And we primarily worked in Sofala and Manica provinces, which are in the high prevalence areas and high USAID priority provinces. So real briefly, we have a lot of findings. The stakeholders reported that this integrated model was never formally adopted at the national level. While there was buy-in from the Ministry of Health and from the Ministry of Women's Affairs and Social Action, they really hadn't formalized it completely. At the subnational level, they were coordinating, but they felt like they were already coordinating to some extent. And then in some of the community-based organizations, there was a history of home-based care programming at the start, and they sort of added OVC programming on over time. We also learned that the CBOs, or the community-based organizations, had very different approaches for targeting OVC. So when you hit a village, how are you determining which OVC are you going to see? Are you doing it by the mere factor that there's people living with HIV in the household? Or are you actively going out and targeting and looking for other children who could be at risk? And this was a very interesting finding and made it extremely challenging to do this research, that these programs report vertically. So you have home-based care forms, you have orphan and vulnerable children forms. They report up completely separately. There is no way at all to look at what integration looks like in the household. We had to go through binders and binders to try to match families to figure out what an integrated household composition looks like. And then when we talked to the volunteers, they said, well, yeah, we feel prepared. We were trained for HBC and OVC, but we feel a little bit more prepared around HBC clients. And while we do have a mixed load of beneficiaries, it's pretty rare to have OVC-only households. And we do have to spend more time with HBC clients than OVC clients typically. That's because many of these people, at least in Mozambique, were severely ill. They're in stage 3 or stage 4. So when a volunteer goes, of course they're going to have to help, a woman with bathing, cleaning, and just doing basic household activities. These are some of the results from the household survey, which I won't go into a lot of detail in, but we did do some logistic regression to look at what were the predictors of a child being seen in a household where there were home-based care clients. And essentially what it means is this active, it means if somebody's really, really sick, this fourth column there, there's more likelihood of a child being seen than if that person with HIV is doing a little bit better. And then we also saw a little bit of a difference in these two provinces, that when you're graduating and leaving from, you're less likely than, the children are less likely to be seen than when they're transitioning. We didn't really see any differences in sex, which is a good thing, and we did see some differences in age in Manica province. And overall, we saw that the more children there are in a household, the less likely they are to receive services. So I know this is a lot to take in, but essentially, it backed up this, we can talk about that in a second. But from what we learned, that the home-based care really is a driver of OVC services, at least in the 4 places where we were able to visit in these community-based organizations. And there was a feeling that some OVC households could be missed, and kids in need of care may not be receiving it due to the needs of the HBC clients. So I think just going back to, the links to policy and organizational supports are, that integration needs to be nationally adopted. It's one thing to be a pilot, but before rolling out to, let's say, 49 of 52 districts, really getting some of that in place at the national level and support. And some of these organizational supports like guidance documents, checklists, and targeting, et cetera, are important. But I need to stop there, so thank you very much. And I didn't see your sign.
Thank you very much, Molly. That was a fascinating study raises lots of questions, which I hope we'll have a chance to discuss. Our last panelist is Karen O'Donnell. She's an associate professor in medical psychology in the Department of Psychiatry, and she's also assistant professor in pediatrics at Duke University Medical Center, and a senior research fellow in health policy at Duke University. She's a child clinical psychologist working domestically and internationally on child development, child maltreatment, and determinants of child and family well-being. Karen?
Be careful.
I will be careful.
Thank you. I'm so much safer standing up. Okay, yes, I am a child psychologist, so I'm going to focus in the beginning on the C part of MCH and on assessment. We talk about the broad developmental context, and I'll focus more on how to look at it. Whoops. Go forward a lot. Go forward a lot?
That was mine, yeah.
You know what, use the other pages better.
Oh, okay.
On the right.
All right, sorry, I'm having a bad day. Oh, here's Molly. Okay. Trying to kill me. Okay. Here's what I'm going to do in 4 minutes. I'm going to talk about what everybody already knows anyway, but hopefully in a way that helps us apply our broader theories. How do we take what we know about children and development in their context and apply it to what we actually do? Background, you probably don't remember because you're all so much younger than me, but historically, go back to the literature or even Charles Dickens, and children were seen as miniature adults. That was it. That was our theory of child development. And then there emerged these arguments about nature and nurture, and they continue today. Hopefully we've gotten a little past that. And we said, well, if nature and nurture are cofactors, then how do we make society better so that we have better children? Well, we have better schools, for example, better health care. And now, lately, I've been asked to talk in places with a lot of violence, Mexico, Colombia. And I think now we aim to reform the child for the benefit of society. So all of it is true, but we've gone one step further, I think.
What do we know about development? You don't even need to read this slide. You know it happens in a maturation. You know that child and context work hand in hand. And as one affects the other, the reciprocal comes true. The child develops in a system, and every aspect of that system warrants our attention. That's not easy. We start a new project, and somebody will come up to me and say, how do we measure depression? And Kate's very familiar with this. I say, let's go back and figure out all the pieces of the context. And it's hard. In fact, we usually fail to do it. Everyone knows the ecological theory, so I won't dwell on it. But I will dwell on the dialectic where what affects the child affects the context. And then that child affects a different context, and it goes on and on. So one of the cases I made just for that model in a country with a lot of violence is what you already know. I told you, you already knew this, that the context, the community context, the political context, and the family context has an effect on that developing child. So we need to measure and look at that. And then, guess what? The child development, emotional development, intellectual development, and how that child then becomes an adult affects the political, community, and family context of where you are, if that's Mozambique or Colombia. So you've got all these multiple factors. How do you do it? There are a lot of ways to do it. We just can't forget to do it. One of the ways Molly and I have worked on is something called the Child Status Index. I'm not promoting it because, unfortunately, I don't get paid if you use it. But I think the issue here is that you can measure in various ways many of the pieces that have an effect on the mother, the child, the family, the community, and the broader community. If you're talking about food security, or if you're talking about the child having someone who loves them and nurtures them. If you're talking about how well they do in school, or do the parents see them as depressed. All of those fit those models that I was kind of shoving at you originally. The items came from the original OVC service domains: food, shelter, protection, health, psychosocial, education. I think this is an earlier version of what Molly was showing. My point isn't so much the index as to remind us that every one of these 12 factors have a strong impact on the family and the community, and we really can't get away with not looking at that. There is a local program in Durham that, guess what, has a similar tool, and they're not all that different. For Durham, North Carolina, maybe whether the child has a health care provider or whether there's a smoke detector in the house. Again, parents with substance abuse, who's helping take care of the mother while she takes care of the baby. Again, all of these factors contribute to what we're looking at in terms of the well-being of the child, the mother, the family, the community, and the broader political context. These are the domains for the family support matrix, but as you'll notice, they're very similar. So that's it. Am I early? Yes. But I love using this slide, and I've begun to realize that many of you younger people don't know who Jackson Browne is, but this is my favorite lyric. When you look into a child's face, you're seeing the whole human race and the endless possibilities there, thus our responsibilities. Thanks.
Okay, so we have half an hour, yes, for question, answer, and discussion. So floor is open. I'm not going to know most of you, so I'm just going to point.
More a reflection on what Molly was talking about. Even here in the United States, we have all these silos. We had a maternal We had a maternal health system and a child health system, both of which went out to families in North Carolina that needed help. The problem is the integration. We've had it in the community care of North Carolina, where we have the mental health component, and we have the medical component, and there's no way for them to work together because of the perception of HIPAA. But the mental health aspects are affecting their medical aspects. They're one and the same. And how you actually break those down and make that work in these places is beyond me, because it's a job for everybody. You're taking people's jobs away, and that's part of the reason I think they have this, is just for job security, employment, so they have money, so the system works. It's you have to sort of redefine it, but give everybody a job. It's more a reflection. I don't know. Maybe you have the answer.
Thanks. Hi, is this one turn? Yeah, it's on. Well, thank you. Yeah, I recognize it probably happens everywhere, and I don't think there is, a magic answer, though. I work on a global measurement project, and one thing I will say is these indicators like that you were referring to, when you can get an indicator of some sort of integrated service, it does help lead toward measuring what that integration looks like. And again, it was really fascinating just in our Mozambique study, in that context, we were not able to look at what the composition of a household was in an integrated program. So similarly, I don't think we're really going to be able to see the change in the integration unless we have, of course, agreement, stakeholder involvement on what integration looks like, but also a way to measure that. So I don't mean to make it overly simplistic, but until you have something to aim for, I think it's pretty challenging to get it into play.
Okay, while we're waiting for people to absorb the coffee and wrap their head around this excellent set of presentations, I'm actually going to tell a little story with a question, which is directed, I think, probably most appropriate for Tricia. I think the issue of integration of services is something that is being talked about in the context of the Sustainable Development Goals. That target that I mentioned for sexual and reproductive health includes a phrase around integration of reproductive health services into healthcare. It reminds me of a conversation I had a few years ago with some of the PEPFAR folks around whether they would consider adopting an indicator of level of integration. And PEPFAR's come a long way, but when this conversation first started this was probably about 4 years ago, the response was integration is not an end in itself. We only care about integration of services, if when you integrate the services, you have measurable increases in each of the components. So integration of services leads to higher coverage for antiretroviral treatment, for family planning, for antenatal care, et cetera, et cetera. And I said, okay, I can see that that's the aim you want to come out with, but that's very much from an institutional perspective. Integration from the user perspective, and in particular from the woman's perspective, is an end in itself, because I'm sure, again, you've all heard the stories and talked to the people where, because of vertical funding and vertical programs, a woman who has HIV, who is pregnant, who has children, has other needs, has to go either to a health facility on different days, or actually has to go to different health facilities to get those needs met. So integration of services, particularly from a woman's or a family's perspective, her ability to go to a single health facility and get her needs and her children's needs met in a single visit is actually an end, I would argue, in itself from the user perspective. The research is still not solid yet on whether there are benefits, in particular in terms of cost savings from the health system perspective. But I think it's a conversation that we don't have enough. So my question to you, sorry, after that long prelude, Tricia, is where do you see us going in terms of this challenge of trying to measure and assess integration? Do you think it should be from the health system side? Or do you see ways to measure this from the user recipient side? Or are there ways that we can marry those two perspectives?
No, sure, that's really interesting. So I'll answer from the perspective of the topic I've worked on the most, which is the integration of family planning into HIV. And I think one of the things you first started talking about, is this on? Can you hear? It is, okay. Was that there's always going to be a lopsided sort of incentive structure. One piece is going to be different or bigger or have a different motivation for wanting to integrate the two or more things that you want to put together. And so there's issues that come up, like you were mentioning institutionally, and people say, look, we have a job to do. If we layer on your thing, that might get to your outcome, but what will that do to me? So a couple of things. We do have some data where people are trying to address those concerns by measuring whether or not there's a negative effect on whatever the base service you started with was. So it can allay those fears that you're going to distract us from our goal and you're going to make our job harder. But the second part of what you were saying is, I think, really important. I do think that there's a certain, so in the end, it has to be both. There are people who are really only going to care about the clinic level outcome data, but there are some people who will care if that mother got better, easier, cheaper care, and they might be motivated by that as well. But we have far less qualitative data about how women or other people experience services when they're integrated or more convenient. But I think we need to increase that to help the people who do care about that. Actually, at the halls of the Gates Foundation, there's a really nice picture on one of the walls that shows a woman, I presume in sub-Saharan Africa, and it has all of these like little bubbles coming out of her saying, you know, she's a smallholder farmer, she's a mother, she's a microfinance client, you know, she's all of these different things as that one woman. So if we can figure out how to get her what she needs, I don't think we should worry so much about, you know, if it takes more work as an institution. I think we still need to make that case.
Good morning. Thanks very much. Tim Mastro with FHI 360. That was a terrific panel, and Anne, a great opening talk. My question gets to something that Tricia sort of dipped her toe into a little bit, is how family planning allows for economic development or economic advantages for women as well as educational benefits. And that reminds me of at the International Conference on Family Planning in Senegal a few years ago, the most memorable talk for me was not from any health ministers. It was the Minister of Finance of Indonesia was up extolling the virtues of the demographic dividend, that by allowing women and families to control the number of children, some of the Asian economies reduced the number of dependent children at a time when productive young adults were having a larger proportion of the population, resulting in the demographic dividend that I know Tricia holds near and dear to her heart. So the question is, how, Anne, following on your talk of, you know, sure, it's a best buy, but it's an even bester buy if you can really say that not only does it help, you know, the medium level, but it's the macro level of an economy. And so Tricia, how do we take that message and get that at higher levels? I spent a couple days in New York last week, so this is the kind of stuff that will move the funders to bring out the checkbooks and say, yeah, it's really worth funding sexual and reproductive health. So it not only helps health outcomes, but it helps the economics of a country.
No, that's great, Tim, thanks. I mean, I think, you know, some of the conversations we had in New York last week, we had an event about the demographic dividend, and how that can really help countries accelerate their levels of socioeconomic development. And I think, I mean, some economists have done models on how some of the countries in Southeast Asia from the 1960s to the 1990s developed so quickly, and they, you know, come away saying about 30% of that can probably be attributed to their investment in family planning programs. And we've seen, you know, sitting in rooms in many African countries, places, when you show someone that data, they do perk up their ears and they say, oh, well, you know, I never really thought about it that way. I thought it was just industrialization or, you know, better investment in trade and things like that. And you say, no, actually, this has a huge effect on the dynamics of your population structure, and it has big benefits for you. So, I mean, I don't think there's a really easy answer. I think it's about getting access to the people who might be able to really affect a line item on a budget, to have the sort of decision-making authority to, when they're sitting down to make their SDG implementation plan for that country, to have that in the back of their head and to say, you know, this should be one of the 3 or 5 things we're prioritizing because of the tremendous benefits it has. So part of it is just finding out who those people are, finding access to them, and trying to figure out what information they need, in what formats, and when, and making sure that we get it to them.
I'm just going to jump in quickly. I totally support and agree with what you said. I think another factor here, and the reason that some people in the sexual and reproductive health and rights community are a little bit reluctant or hesitant to support the sort of demographic dividend approach is the concern that it's going to lead back to population growth targets, contraceptive prevalence rate targets, total fertility rate targets. There's a concern that if population growth rather than what women's desire for smaller families is what's driving the policies, then we run the risk of going back to those coercive programs that we had in the 60s and that in some large countries we still have today, even though they're called different things. I think from my perspective, it's a delicate balance, but I think what we need to do, what we as a community need to be better at doing, is understanding what motivates policymakers and selling, in essence, the investment in family planning programs using arguments like the demographic dividend, but then just be very clear that when programs are being designed, that the rights-based approach is absolutely fundamental to how services are provided, how measurement targets are set, et cetera, et cetera. It's a challenge, but I think it's one we have to take on.
Hi, I'm Kate Wetton here at Duke University. I have a question for Eve and the panelists about the integration of the church. And when I think about services that are being provided, for example, for OVC and others, and you have case managers who are going in, and we think of them as being linked with health departments, with health organizations, or we think about NGOs. And but we know that that religious organizations are very important to communities around the world, and they're providing a lot of services. And people there are not generally being trained, so that's something that's unique that you're doing. Can you speak to what it's been like, or what you see as the ability to integrate into other services with the churches? And I think we often have a lot of fear. Traditionally, we've had a lot of fear of working with churches and those religious organizations and what that will turn into. So I think it's interesting. That's kind of the work that you're doing. And so for Eve and other panelists, what do you think about that?
Sure. So hearing the rest of you talk, it's started my brain going even broader than I was thinking about in terms of the ways that the types of programs that I talked about could be integrated into these clinic services. And what you were just saying, Tricia, about people being afraid of work being layered on them and increasing the burden of creating this cadre of community health workers, and then everyone has an idea for what they should be doing. And that quickly becomes more than a full-time voluntary job. I think that those community health workers and the people that they're seeing are already working with churches. They already have churches, not necessarily churches, religious congregations, women's groups, people who they already go to for advice. But they're doing that on parallel streams instead of working together. I think those referral pathways are often already in place. Community health workers referring people to those community resources. And I think acknowledging this and integrating the two in terms of integrating training is probably the best way to use those resources efficiently. I think it keeps community health workers and other people in the health sector for doing things that they feel like are other people's jobs, really, in that community. And in my experience, religious organizations, those leaders have been more open to training, more open to a broader range of reproductive health services, because in these communities, they have seen firsthand the consequences of people not having these services. They know the children, they know the families, and so they struggle with theological beliefs. They struggle with traditions of the church and of the community for things like family planning and things like adolescent reproductive health services. But in that struggle, they're willing to engage in that conversation, and I think our fear sort of on this side is really standing in the way of that.
Okay, Kat, and then in the back there.
Sure. Hi, Catherine Turner with IPASS and UNC. Thank you to all the panelists and to Anne. I want to go back to this issue about how we use data for advocacy, and I absolutely agree that we have to really extol the benefits of not only health, but also the economic benefits of contraception and other women's health care. And then this warning about we do need to talk to policymakers about the benefits to countries economically by investing in family planning and women's health services. But one of the best presentations I've heard on the topic was from a World Bank person who was really talking about how we can educate family members and heads of households about the ways that investing in family planning can really benefit their families. And so I think that we're looking at multiple levels of education and, again, use of data for advocacy to talk to state heads and policymakers, and also the kind of direct-to-consumer approach. How do we do a lot of consumer advocacy and educate the population so that, and talk to people in a way that they can really understand you as a mother, you as a father, how does use of family planning, you as a mother-in-law, think of who the influential people are around the world in families, how do we speak to them about the ways that use of contraception and women's health care can really benefit their families on a very tangible, individual level? I'd love to hear your ideas about that.
Yeah, I mean, so I think it's a really interesting notion about, going sort of direct to consumer with the message, right? I mean, I think in part that's important, and to especially make sure that people are aware of where they can go get services. I think an equally important part of that, though, is that there are enough people who really do want it, who might not be able to get it, or they're not allowed from their husband, or they have sort of other barriers that sometimes I get a little shy about the notion of, that we're trying to convince people, that we have to go into a home and convince you that, if you use family planning and you have a smaller family or you have fewer children, it's going to be really good for you. So I think there's a balance between pulling out the demand that's already there and making sure that those people and their partners can actually access it, and then sort of blending that all together in both of a sort of, a rights-based but also a data-driven approach to make sure that the people who want it first can really get it. There's places, I think, in northern Nigeria where the desired, number of children is 10. I don't know what to do about that. I'm going to sort of laser target the people, the women who say, yes, I'm done childbearing, or, I'm going to have 3 children and I want help doing that. So it's mixed.
Sure, go ahead.
I just wanted to add, I supported operations research for about 5 years on a bilateral in northern Nigeria in 2 states, where we had a lot of challenges with family planning and uptake of services. Particularly, there was a big emphasis on modern contraceptives, but the barriers for even just taking, a pill versus, actually doing injections or, other forms of more modern contraception was incredibly challenging. And the issue is there, as you know, working with the religious institutions that are there and the incredibly conservative environment. So one of the things that has been a little bit more effective is working directly with imams when you're able to, right? And some of the religious leaders in those communities, as well as the ward development committees, so using the community structures. And most of those ward development committees are male. They might have 1 or 2 female members, but the majority of them are male. And it's hard to play into that and try to work more through the male, building of their capacity. But still, after 5 years of a tremendous amount of funding from USAID, they were target states, right? Massive amounts. They weren't even able to move any of the indicators on the DHS in 5 years. So it's mind-boggling and challenging to affect that kind of change. And there are larger, there's a very large family planning advocacy project called HP. It's now HP Plus. It just was awarded. It's a global project. And they do a lot of work of modeling and advocacy for state leaders and levels.
Actually, really quickly, let me just give you an example, though, of where that has really worked. So we partnered with an organization to do an integrated project adding family planning information and referrals to the Green Rangers, which is an environmental conservation group in Kenya started by Wangari Maathai. And so it's, this massive force of grassroots women who go around and educate people about the, the benefits of planting trees and conserving your land and things like that. And they had said, you know what I think we need? We do need to blend in the messages about family size and things like that. And they did, and we helped them do it. And we saw really good results where some of the men, maybe I think, who were slightly indifferent, maybe not even opposed, but a little indifferent, they were then able to say, oh, okay, no, I see. We've been struggling with climate change, our plots are getting smaller and smaller and smaller, they're getting dried up. Like, I see what you're saying now, that maybe this could help us get more out of what we're doing. So that was a nice example of kind of going right to the household with that message.
Hi, I'm Donna McCarrier with FHI 360. Thanks again for the great panelist talk. I had 2 pieces of information and 1 question. So 2 pieces of information. I wanted everybody to be aware of a new funded program from USAID called the Passages Project, whose goal is to shift social norm change to improve family planning use and also utilization of other maternal and newborn health child services. We're part of a consortium that's led by IRH. The first year out of the box, we're going to have a very robust webinar series about what we know about social norm change and social norm approaches. And I think they're really important, as Anne highlighted. The demand side is an obstacle to increasing utilization of all the services we hope to promote to improve the health of women and their children. So if you want to learn more about Passages, you can talk to me or just go to our website or IRH's website or SAVE's website. There's information there. And the first year project is, one of the first year research studies is religious-based with the Tier Front and the DRC, working through religious organizations to shift masculine perceptions about masculinities. The second piece is several years ago under the YouthNet project, we had developed a Muslim and Christian life family education curricula, and those are available on the IYWG website. If you just search Muslim and Christian life family education, they will come up, and I think they're resources people can use. So now to my question. I'm working on, we have an R34 pilot study in Zambia with adolescents living with HIV. And what's sort of tripping us up a little bit, and this is really primal, is like we are working on an intervention for caregivers and their and adolescents. And so it's this definition of caregiver. So when I was hearing about the work in Kenya, I was just interested about how you're defining, families. That's just an interesting. It's very interesting because adolescents living with HIV tend to have a different. Just a different family makeups. And so I just wanted to hear a little bit more about your definition of family. And for us, that has implications for how far our intervention can actually go, defining our definition of family. So that's my question for you.
I'm going to jump in really quickly and just add another question to that, which is, and this is both for you and for Karen potentially, which is around this question of who is most effective at conveying information to and counseling adolescents. I've seen some research where, interestingly, a lot of adolescents in the developing world will actually say that they would prefer to get specifically sex education from their parents, but the parents don't want to play that role. So I'd be interested in your thoughts and your experiences on that front.
So probably the best place to start is defining family. You're absolutely right, and just from this pilot study, we have a lot of different structures for family. And one of the main themes that has come up in our work is the struggles from orphans who are in these families who are not necessarily seen by the other people in that household as part of that family. And so we are considering them very much a part of the family by really emphasizing the idea of household and the people that come in and out of that household, who is involved in the problem solving. Last time you had a problem, who was here? And those people are now our family. And that's who we encourage families to bring in for these types of counseling programs. And I think that going back a little bit to this idea of who wants family planning, I think there's where the women want the family planning and where both the woman and the partner want family planning. One of the most interesting graphs that you showed, Anne, was that it wasn't necessarily lack of awareness that was blocking women from getting contraception, but it was their partner or someone else in their family resisting that. And I think a lot of our rights-based approaches emphasizes having women stand up to their husbands to convince them. And they don't I shouldn't make such a general statement. Often women want to maintain the roles and traditional roles in their household. They want the man to be the head of the household. They want the man to approve of what they're doing. And regardless of how we might want to change that in the coming years, I think going back to that relationship is sometimes important, not just the husband, but the mother-in-law, not just the husband and the mother-in-law, but also even some of the older children or biological parents of these orphans really getting on board. And sometimes that's about their problem-solving style in that family, the communication. Husband's not really understanding why the woman might want contraception, and maybe it's to contribute to the household economics and not to block having more of a fruitful family, which is sometimes assumed by them. Did I miss?
This will be the last question of this session. Hey all, thank you so much for all that you had to share. And I was hoping that you could just help me on some pieces that I might have missed. We've talked a lot about the community and the household level, and then we've also talked a lot about these national policies. And there was some examples of, you know, state level ministries, but can you help me understand where there seems like that big gap, and I'm sure we just don't have time to cover it all, but maybe you could provide a couple of examples of how that big space where a lot of really important work is getting done is done in yours. It's really open to all.
Jenna, say which space? Are you talking about like national?
I think
between.
Yeah, I think one of the things, I mean, you've worked in Kenya. In Kenya, there's been this whole move towards devolution. And so, you know, the ministries of health, I mean, in Pakistan at one point even abolished its National Ministry of Health altogether. There's been a significant trend towards devolution to the state level authorities. Is that what you're talking about, is kind of how that?
Well, so we talk a lot about the household village level and then national policies. And I know that there's a lot that happens between there. And I'm wondering if any of your projects are working within that space. That was probably not any more illuminating. Sorry.
No, I think you're right. I mean, it depends on the opportunity and what the project is. You know, that's one of the issues is what are the donors willing to fund and what is their mandate. But, you know, for example, in measure evaluation, which does more of evaluation capacity level, capacity building, so use of information for decision making, we do have projects where we're able to work in countries, for example, in Nigeria with the national government, with the Ministry of Health and other ministries, and then it rolls down to subnational level where we're working with the state ministries in a very similar type of environment, and then the next level down from that would be the LGA level, the local government association level. So it does, and then you get into the community-based information systems. And so ideally, you know, if funding were available and you'd be working within all of those different structures on the same type of, or a similar type of approach or adapted approach depending on where they are. But I don't know that we always get the opportunity to do that.
Okay, I know there was more interest in more questions, but I'm going to wrap us up and make sure we all get our coffee break on time. So can everybody join me in giving a warm thanks to the panel? I think this was a great discussion.
So I have the pleasure of introducing Gavin Yami today. He is going to be speaking, he's going to be closing this afternoon, but he's also he's the facilitator of this panel. We're really pleased that Gavin has joined us here at Duke. He's probably on day 20 of being at Duke. Each day he announces how many days he's been here. He trained in clinical medicine at Oxford University and the University College London, in medical journalism and editing at the British Medical Journal, and public health at London School of Hygiene and Tropical Medicine. He was deputy editor of the Western Journal of Medicine, assistant editor at the BMJ, British Medical Journal, and founding senior editor of PLAWS Medicine, and the principal investigator on a $1.1 million grant, a grant from the Bill and Melinda Gates Foundation to support the launch of PLAWS neglected tropical diseases. In 2009, he was awarded the Kaiser Family Mini Media Fellowship in Global Health Reporting to examine the barriers to scaling up low-cost, low-tech health tools in Sudan, Uganda, and Kenya. So really important background to the conference that we're having here today, where we're looking at how to get research into policy, how to change programming around the world. He also serves on 2 international health commissions. There's the Lancet Commission on Investing in Health and the Lancet Commission on Global Surgery, although he is not a surgeon, as far as we know. Not today. He's been an external advisor to the World Health Organization and to TDR, the Special Program for Research and Training in Tropical Diseases. He's published extensively, and we're very pleased to have him here today. Thank you.
Thanks, Kate, for the very kind introduction. This is way too low down for me, but perhaps not for others. So I'm really delighted to be moderating this panel on technological and social innovations for maternal and child health, a topic very dear to my heart. And it really could not be more timely. Last week, as we've heard about this morning, UN member states adopted the Sustainable Development Goals, 17 goals, 169 targets, what the economists rather cheekily called the 169 commandments in their takedown of the SDGs. What we know for sure when we look at the targets is that they are extraordinarily ambitious. They really do motivate us to aim much higher and much faster, right? They call on us to reduce maternal mortality by 2/3, MMR from 210 to 70 in just 15 years. That is serious acceleration of progress. And they call on us, the language says, to end avertible newborn and child deaths. Those targets, without innovation, those targets are a total and utter fantasy and fairy tale. We cannot get there with today's tools alone. We are going to need tomorrow's tools. And tomorrow's tools alone won't be enough. Tools on their own, as you know, don't just sort of deliver themselves in a sort of atomized way dropping from the sky. We are going to need systems, complex systems that involve financing and governance, and that throw out all sorts of questions on issues of access and inequities. And so those are some of the themes that I hope our very distinguished panel will get into over the next hour. And what I thought I would do is just very briefly introduce our panelists all in one go, and then I'm going to pose a question to each of them as a way of kind of framing their short opening introductory statements. So Eric Green is an assistant professor of the practice of global health here at DGHI. His primary research interest is on how technology can improve health and health systems in low-income settings. To his left is Lavanya Vasudevan, who is a research scholar at CHIPA, I believe it's called, the Center for Health Policy and Inequalities Research here at Duke. Her research focuses on understanding disparities in maternal and child health outcomes. To Lavanya's left is Nimi Ramanujam, the Robert W. Carr Jr. Professor of Biomedical Engineering, a Professor of Pharmacology and Cancer Biology, Professor of Global Health, and Director of the Inspirational Center for Global Women's Health Technologies here at Duke. And to her left is Lenita Dorflinger, who is a distinguished scientist and Director of Contraceptive Technology Innovation at FHI 360, which, as many of you know, is a non-profit human development organization that is currently working in over 70 countries. So a really stellar panel, a great honor for me to moderate this session. And I wanted to start with Eric, really asking about taking successful interventions to scale. This morning we've already heard about a whole series of tools and services that we know work, but where in some cases and in some settings, we've kind of reached a plateau. I've done some work in the past, for example, on childhood diarrhea, where you could, for pennies, be saving hundreds of thousands of lives with just simple oral rehydration therapy and zinc tablets. In many settings, we've really reached a plateau on scale-up. And time after time, we see this again and again. And I'm interested from you, Eric, in how technologies can help us to solve this problem of stalled scale-up. Over to you.
Well, thanks, Gavin, and good morning, everybody. Guess I'll click. Here we go. Wow. It's like my class. That's great. So Gavin mentioned about we're not going to meet these goals unless we use new tools. I'm actually going to make an argument that we need today's tools or yesterday's tools, but new processes in place. So the goal is how do we get to 100 million? We want to scale up evidence-based treatments so that everybody who needs access has access. But the reality is, or what it sometimes feels like, is that we're just making a drop in the bucket. Now, of course, that's not true. There's been a lot of success in global health. Smallpox, malaria control are good examples. But sometimes the examples aren't there. And one key area is maternal and child mental health. And you don't have to take it from me. MHGAP is the largest initiative toward scaling up evidence-based treatments, and they'll tell you that 4 out of 5 people aren't getting access to evidence-based treatments. And when they do, they happen to actually not be evidence-based or high quality. So the challenges are, first, there's a really high need, and there's very few resources, skilled mental health professionals to delivering to this need. When they do exist, they tend to be clustered in urban areas. That's where you and I would live as a psychologist too. So if you're the rural poor, it's going to be really hard that you're accessing any of these treatments. Mental health treatments are also different than other global health challenges in that they're really high touch. So a vaccine might be an initial round and some boosters, but mental health depression treatments might be every 2 weeks for a few months. So if it's hard to reach a person one time, it's really hard to reach them on a sustained pattern. So what are the solutions? In global mental health, we talk a lot about task shifting. So increasing the availability and proximity of treatments by moving to lower skilled providers. It's lower cost, but the folks who you're training up for this don't have as many skills. But it does seem to work. In Pakistan, as you'll hear about later, they have an interesting model of lady health workers, community health workers that deliver a cognitive behavioral therapy for perinatal depression. And in their studies, they've found it reduces depression by more than 50%. So we know that it works, and it's been tested in the scale of hundreds. It's been maybe scaled up in the low thousands. But the real question is, how do you go from hundreds to millions, and what are the barriers along the way? Certainly, these will look familiar to folks that if you're using lay health workers, we have barriers in training and supervision, case finding for sure, and response to treatment. These are all things that stand in the way of us getting to millions, and there are probably many others. But my point today is that aside from innovations in financing, task shifting is probably a big part of the answer to the fundamental mismatch between need and resources. But to make this task shifting work, I believe we need a good amount of boring technology to be implemented well. I'm not talking about the technology-first solutions that probably make many seasoned global health veterans in the room roll their eyes when they hear about these things. I'm talking about very boring technology, hardware that already exists in people's pockets, and servers that are running smart algorithms to maximize learning and create feedback loops with users. And of course, all of this within an interface that works for users. In the Pakistan example, this might look like a hotline that can be advertised by the radio, over the radio. And when a new mother calls in, she gets an automated screening information and the opportunity to connect to live support. Maybe then she's matched with a community health worker based on her location. And the health worker gets a message about the match. Computers don't forget like we do, and if you're asking a health worker who's sometimes unpaid to do one more task, they're going to forget. So the system can reach back out to both of them if contact hasn't been confirmed. So the process can go on like this, and this is just one example. Missed appointments are monitored, and regional supervisors can track progress on easy-to-use dashboards. The key is that all of these components exist. What's really been missing, I think, are the analytics to be able to hold them together and to guide decision-making and resource allocation. My own experience suggests that one reason for this is that this work really requires diverse teams with diverse skills. The people adapting mental health interventions are by and large not the people who know how to build analytic systems. And the flip side is true as well. The people who are building these systems aren't tuned in to these global mental health challenges or many of the other challenges that we've talked about today. So I think what we need is we need teams that are more integrated to be able to tackle these challenges, not to develop new technology per se in terms of hardware, but to create the analytics that can help us be more speedy. The traditional academic model of do a study now, report on it a year and a half later when you finally get around to the data analysis doesn't work. In this model, we need to be able to analyze data in the moment, daily. And in order to do that, we need a better blending of people with the right skills. So interventions coming together with people that know how to do this work. So I'll just end by saying I do think that these goals can be met, that this revolution can happen. But I think the story of it's going to be a pretty boring one in the end.
Thank you, Eric. Normally, when we hear technology, it's, high tech, cool tech, disruptive tech. So it's great to hear about boring technology. So Lavanya, the World Bank estimates that today there are around 6.3 billion mobile phone subscribers. And not surprisingly, we in the room and around the world in the health community are extremely excited about the potential usages for mobile technology, so-called mobile health or mHealth, that leverages mobile technologies. I know that you've been involved in using mobiles, particularly around vaccination scale-up. Could you share with us your experience?
Thank you, Gavin. And I just want to say, today we live in an age where there are more mobile phones and mobile phone subscriptions than people have access to clean running water, electricity, and landline phones, as one might expect. And in our research, we have tried to leverage this technology to improve health service delivery and uptake of health services. And today, so I'm really excited to discuss. Oh.
Turn on child.
So I'm really excited to discuss opportunities for mHealth in the delivery and uptake of routine immunization services. So as we all know, globally, vaccinations over 2.5 million deaths annually. And this is largely due to the success of routine immunization services in reaching children. However, despite really high national vaccination coverages, regional disparities exist. And in fact, it's estimated that over 19 million children remain under-vaccinated each year, and this includes children who either receive delayed vaccinations, do not receive the complete set of vaccinations, or are not vaccinated at all. And in fact, children in rural and remote areas and from socioeconomically disadvantaged backgrounds are more likely to receive delayed vaccinations or no vaccinations compared to their urban and more wealthier counterparts. So the challenge before us really is to identify strategies through which we can increase the effectiveness and efficiency of immunization delivery, meaning we have to identify strategies that reduce supply-side barriers to immunization, while in parallel trying to reduce the demand-side barriers that allow us to improve uptake of immunization services. So mobile technologies have emerged as useful tools in this context, not only because they're so ubiquitous these days, but also because they have the potential for allowing us to collect real-time data and improving the way we make decisions and allocate resources. So in our work, we have looked closely at information constraints, specifically in routine immunization services, and the role that mHealth can play in this process. And before I talk about the system we have developed, I just want to walk through some of the constraints that we have observed in the field. So one of the biggest things we observe is the burden of paper-based record keeping on health workers. So vaccinators who participate in routine immunization services often are required to duplicate data across multiple ledgers. And this takes time away from other critical processes such as counseling women and other parents. So the current sort of standard for recording data on paper-based system is something that looks like this register. And what this does is it prevents the health workers from being able to quickly identify and prioritize children who have missed immunization services, because immunization visits are recorded date-wise, not client-wise. And really the only client-wise record of vaccination that's available today is in this sort of fragile cardstock vaccination card that now becomes the burden of parents to maintain. And it also becomes the burden on parents to remember appointments and when their children are due for vaccinations. So the system on a whole at this point is really reactive, and we need to change that. In addition to that, counseling on the importance of vaccinations right at this point of time is very passive. And as I mentioned, health workers don't often have the time to actively counsel mothers who bring their kids in for vaccination on why it's really important to vaccinate. In addition to all of these constraints, there are currently no formal mechanisms to notify parents when there are delays or closures or changes in immunization service schedules. And this means wasted trips to the immunization centers, delays, and frustrations. So we designed a mobile phone-based virtual vaccination registry system specifically to reduce barriers to vaccination. And this was work that was led by the Johns Hopkins Bloomberg School of Public Health in collaboration with Empower Social Enterprises, which is a company based in Bangladesh, along with the Ministry of Health and Family Welfare of Bangladesh. And this work was funded by the Bill and Melinda Gates Grand Challenges Exploration Award. So our system, as I mentioned, was specifically designed to address the constraints in routine immunization. And what we did was we included modules that allowed for the registration of pregnant women and newborns. And in addition to that, provided job aids that vaccinators could use to counsel women on the importance of vaccination. So registration of newborns in our system then allowed our system server to generate automated vaccination schedules, which could then proactively send reminders to parents about upcoming vaccinations instead of waiting for them to miss vaccinations. In addition, we had this innovative feature where we provided vaccinators the ability to notify clients whenever a vaccination outreach session was ongoing. And this was particularly designed to prevent missed vaccinations due to changes in vaccination schedules. So in innovating MTICA and working with the mHealth space, we learned several lessons, including the need for innovations to focus specifically on constraints. So mHealth innovations have generated a lot of enthusiasm among donors, governments, implementers alike for their potential to not only reach populations at large scale, but also, like I said, for the potential for real-time data collection. But it's important to recognize that mobile devices are simply tools for the delivery of effective interventions, and that any mHealth intervention is only going to be as good as the health intervention that it's trying to deliver. To be effective, mHealth cannot be innovated in a vacuum. And what has worked for us is to take this constraint-based approach to identify components of our system that are appropriate for the context in which we are innovating. So I would just like to close with the thought that as we move into the era of the SDGs and universal healthcare, I think it's critical to focus on innovating for the system, and this includes not just the health system, but also the provider and the client. And we need to think more in terms of integrated interventions that will allow for investments in resources for the scaling of effective mHealth innovations. Thank you.
Thank you, Lavanya. And innovation in a vacuum is something I want to ask you about during the Q&A. Nimi, I read a great piece about you and your work recently in some magazine. I think it was a Duke magazine, and it was really all about your lab of entrepreneurial engineers. And the reporter interviewed you, and you were quoted as saying, "The aim isn't to create a bunch of entrepreneurs, but to make them aware that entrepreneurship is part of the process through which technologies make it to the community at large." So I wanted to ask you about this marriage between engineering and social change. How do you marry the two? What's your experience, and what can we learn from what you're trying to do?
Thank you, Gavin. So I'd like to respond to that question through an example of something that we're working on that we think is an engineering solution to a major health disparity and how we're tackling this problem through a technology lens. And I'd like to begin with a picture of Henrietta Lacks, who came back into the popular press because of her immortalized HeLa cells that have been actually a boon to the development of better medicines for a variety of ailments. But that's actually not what I want to bring your attention to. Henrietta Lacks died of cervical cancer when she was 31. And this is true of many women that die of cervical cancer today around the globe. So things have changed in high-income settings because of some key innovations that took place around the time that Henrietta had cervical cancer. So George Papanikolaou actually came up with the Pap smear to be able to take a smear of cervical cells and look for abnormality. And he actually wrote a book around the time that she died. And then Hans Hinzelmann developed a colposcope that is a low-power microscope that can be used to look at the cervix to look for abnormalities once a Pap is positive. And in fact, this is what we benefit from here in the United States. Women in the general female population get a Pap smear. If the Pap's positive, then she would be referred to a specialist who would look at her cervix with a colposcope, apply vinegar, look for acetowhitened sites, and then take a biopsy to confirm the presence of disease. And in fact, the incidence and mortality from cervical cancer has plummeted in the United States and many Western countries as a result of that. But there's a stark difference in what we see in resource-constrained settings. First of all, the Association for Cervical Cancer Prevention says, well, let's take a modified form of current screening paradigms for cervical cancer and adapt them to resource-constrained settings. Well, there's one big issue, which is there's a shortage of physicians and nurses that can implement this fairly sophisticated procedure, so we just don't see rooms that are staffed for cervical cancer screening in some parts of the world. And this is a clinic in Moshi, Tanzania. And then in the instances where there are human resources to do screening, the technologies that are available to these health providers are actually less than adequate. So why is it that not only are we dealing with a health worker shortage, but also with inadequate technologies and expecting to essentially do screening in this manner in places where this disease is most prevalent? And I think what bothers me is that we're essentially taking what's used here and trying to essentially constrain it in any way possible to make it fit within the setting and then just transplanting it there. And I'm a big fan of historical events, and I always like to look at history to sort of think about how did we arrive at where we are today and how might we think differently. And one of the things that I'd also like to point out is in addition to these sort of glaring omissions, there's also another issue that's universal, which is, have you ever thought of how enjoyable a cervical cancer screening exam might be for those of you who, for half of the audience, presumably? Because I know that there's quite a bit of attrition no matter where in the world you are, because frankly, this is an exam that was designed by men for women. So, no offense, I mean, it's been a great technology, but we need to just rethink some of the assumptions that we have made. So we went back to ancient history, not contemporary issues that were in terms of Henrietta Lacks, but really going back to ancient civilizations. And actually, it's interesting when you think about the fact that the first speculum was actually found in the house of Pompeii. And do you see much of a difference between what is used today and what was used then? I would say not much. And there's actually a really dark history, a more modern history associated with the speculum. James Marion Sims is considered the father of American gynecology, and he used gravy spoons on purchased slaves to figure out how to optimize the modern speculum. So I think we should question old assumptions. But the good news is the tampon was designed by women for women. And here is a tampon. Actually, this was done by the Egyptians using papyrus. And so we thought, what if we could just rethink the way a cervical exam could be done? Could that address all of these bottlenecks that we have talked about? And at the same time, could we actually make this a, I don't know, a more comfortable procedure for women to get this important test? So this is the vision. And the real vision is if you could actually put all of the technology you need, and in this particular case, you want to be able to see the cervix, because that's ultimately how you're going to know if a woman has disease or not, into a tampon. And this is a mannequin, not a patient, but this is the basic idea. We actually did just this. We thought, can we put a camera, a light source, into a tampon, and can we actually get rid of the speculum, and can we get images that are as good as what you would get with a $20,000 device, so that potentially this could be task shifted down to community health workers, or potentially women themselves if they're incented the appropriate way. And we know this is done in the case of maternal health and safe deliveries. Can we actually not compromise on the quality of the technology? I think that's unacceptable. You should get good quality care no matter where you are. And can we get rid of the speculum so that it's one less step in the workflow, and also it's just really a much more comfortable procedure, and I can tell you that I've personally had the experience. But it's fortuitous. How did we get to the point where we could make the technology really good? It turns out that the colposcope that was invented by Hans Hinzelmann is about that the actual device is about a foot away from the cervix. And when you're far away, think about looking at the stars. I mean, it gets very expensive in terms of technology. And we thought, wow, if you put everything in a tampon, you can use consumer-grade hobby cameras and light sources. And because when you put them close to the cervix, your pictures are as good without the added cost of expensive technology. And that was fortuitous. We really were thinking about making the exam more comfortable, but the benefit was that we could reduce the bill of materials to about $200. And presumably, you know, if you just double that by a factor of 2, a $400 cost versus a $20,000 cost without much in the way of cost stripping. And so this is the basic idea. You put a tampon in, you take a picture, and again, this is a dream that you might have community health workers do this, or you might have women themselves do this and take pictures that could be SMS to the appropriate provider to essentially make a decision. And, you know, one inspiration was, ooh, my time is up. I get carried away. So one inspiration was this one stop in East Africa, in Kenya, that I saw, where they actually have clinics to do cervical cancer screening for sex workers at the truck stops. And, you know, they didn't have the technology or the skills to be able to implement cervical cancer screening. And so we keep thinking about how can we get the mountain to Muhammad with these technologies. So I'd like to just conclude by showing the traditional instrument and our technology, and the fact that at the end of the day, we're able to get comparable images of cervices with this technology, and we can get rid of the speculum in doing so. Thank you.
Thanks, Nimi. Certainly, community health workers, task shifting, self-screening, even self-care are themes that appear to be recurring throughout today. Lenita, so FHI 360 has been one of the real leaders in expanding contraceptive technologies in low-resource settings. One example is a long-acting contraceptive implant that's manufactured in China that I know that you're supporting, called Sino Implant. Why did you and FHI 360 get involved in this activity? And what are some of the difficulties and challenges that you may have encountered in supporting a manufacturer based in the Global South?
Alrighty, thanks, Gavin. Oops, I want to make sure I... One more to go. One more to go? Okay. I'm just going to use the page down. Very much. All right. Thanks, Gavin. As Gavin mentioned, FHI 360 has been intimately involved for the last 8 years on the global introduction of Sino implant, which is a product made in Shanghai, China by a company named Dahua. And I would love to start by telling you all why we got involved in this. And it's all around contraceptive effectiveness. And I do attribute the Guttmacher Institute for my data here, I'm just joking. Over 90% of unintended pregnancies occur among women who are using no method or less effective methods of contraception. And longer-acting methods like implants and IUDs, not only are they inherently effective, but they don't require regular action by users, and continuation rates are much higher. And as a result, you see a much higher use effectiveness amongst clients. But in 2007, when we got involved in this program, contraceptive implants were essentially not available in developing countries, or their availability was extremely limited. And the major reason was they were expensive, was the cost. At the time, there were 2 products that lasted 3 to 5 years, and they ranged $20 to $25. And this was just way too much for a donor to consider, when the alternatives of less than $1 for a depot injection, or 27 cents for a pack of oral contraceptives. But basically, if you think about it somewhat differently, if you look at the impact of effectiveness on outcome, we see that if in this analysis done by some of my colleagues at FHI 360, if 20% of users of shorter acting methods actually switched to implants in this period, the analysis was done in 2007, over a 5-year period, there would be a dramatic impact to reduce unplanned pregnancies, abortions, and maternal deaths. And this was looking at switching. If you think about actual uptake, the effect would even be more dramatic. So we were really committed to seeing how one could expand access to implants and get donors to think about, even at the price, making the product available. And then serendipity. And I think so much of science is serendipity. One of my colleagues was at a World Health Organization meeting, Marcus Steiner, and he learned about a $5 contraceptive implant that was made in China. And we got very excited about the possibility of this. And the Bill and Melinda Gates Foundation funded us to do an assessment of the feasibility of bringing that product to the global market. And so we spent about a year making a number of visits, doing good manufacturing practice assessments, and building a relationship with this company. And bear in mind, this company was a one-product company, and they still are a one-product company. Nobody spoke English, entirely Chinese-speaking. They were very skeptical of foreigners coming in. And I think the most astounding thing to me was they didn't even know who Bill Gates was. And so we were just like, what? You don't what? But we spent a year, and we got very excited about the possibility that this could be a real product that could make it to the into the developing world. And the Gates Foundation agreed with us and extended our grant to develop an innovative public-private sector partnership to bring this product to the global market. And we've brought together well more than 24 partners, almost 36 partners now, for this program. And FHI 360 has worked as the global coordinator, bringing together groups to do GMP support, quality testing, an export agency. They did not have any export capabilities, procurement and service delivery groups, and distributors to do local registrations, ministries of health, and research partners. And our role in this was to provide technical assistance to support the introduction. And our technical assistance included support for national registrations. We worked very closely with the distributors, doing product quality testing and post-marketing surveillance studies in local countries, providing technical support to country introduction, and I think perhaps most importantly, providing support for the WHO pre-qualification. And for those of you who don't know, the WHO pre-qualification program is one that provides assurances to donor and procurement groups of quality, safety, and effectiveness of products. And it's particularly important for those products that don't have or not registered in countries with stringent regulatory approval like the FDA in the US or in Europe. And I think beyond that, that process created a hiccup for us because in assessing the data, WHO actually asked for a new clinical trial to provide 5 years of clinical data on this product. And I think that was a high hurdle that we've met, and we're 4 years into the study now. And finally, I think one of the most important things we did was create pricing preferential pricing agreements with distributors who were doing local registrations to assure that our original goal of getting a low-cost product to women was held, that there wasn't price creep at any point during our program. And over the last 7 years, we've seen registrations in 24 countries. Originally, when we first met Dahua, they were marketing in China and in Indonesia, and the product is under review in over 10 additional countries. Those 10 countries are really ones that are waiting for WHO pre-qualification, which we hope to achieve sometime in 2016. Now, without WHO pre-qualification, oops, let me get rid of this. All right. Without WHO pre-qualification, the large donors will not buy products. But we were still able over the period of 2009 to 2013 to see 1 million Sino implants procured. And estimates of the dramatic impact of this $1 million of longer-acting, highly effective methods were there's dramatic reduction in unintended pregnancies and maternal deaths and abortions averted. But importantly, the procurement of these 1 million Sino implants really was done at a cost savings of about $10.5 million compared to what donors would have had to pay if they were buying the alternatives at the time, at the prices at the time. So I'd like to spend the last minute or two just reinforcing this link between price and procurement opportunities and introduction with 2 slides. This slide shows the price over a 5-year period with the green line at the bottom. I don't think I have a pointer here now. The green line at the bottom is the price of Sino implant, which has remained fairly stable over this period of time. And the 2 alternatives, Jadel made by Bayer Healthcare and Implanon by Merck, started to creep down, and a lot of this had to do with discussions with donors. But in the end, between 2012 and 2013, there was a volume guarantee that happened around the London Summit of Family Planning in order to try to expand access. And some of us think it's more than coincidental that in exchange for a volume guarantee, these two large manufacturers brought the price pretty much in line with the price of Sino implant. They won't admit it, but we think it's coincidental. So I'd like to close just to show you again the impact of price on procurement. The jump here between 2008 and 2011 in implants was fairly small. Some of that was attributed to Sino implant and some the purchase of other implants. But with the volume guarantee and price reduction, there was a dramatic increase in global procurement, again, of the 2 WHO pre-qualified and FDA approved products. But we do like to think that Sino implant has played a very important role in putting pressure on the price structure of the other implants, and that over time, once WHO pre-qualification is achieved, this will have a very large impact on women's lives globally. Thank you.
What a great panel. We have 20 minutes for questions. I'm going to take the prerogative of asking a few. In fact, Nimi just whispered a question to me. I'm going to just put you on the spot here, sorry, saying how fascinated you were by this and wondering what's the commercial pathway here for this product. I think there are mics that work.
Yeah.
Great.
So we have been working. I don't know if that's. Is it on? Can you hear me? Is that on? I guess I just need to get closer. Yeah, so we've worked with a number of distribution partners that have done local registration, and so the availability has been through this distribution network of multiple partners. Dahua is really not at this point in time capable of doing their own international marketing. They have one person now that speaks English, and I think that that it's been a huge challenge to take a company that has a single product and then try to compete with large multinational companies like Bayer and Merck. And I should say that, and maybe it's not politically correct to say, but there's been a lot of interesting and intrigue that has gone on over the years because of the pressures that this product is really putting on those other manufacturers.
Thank you. I wanted to return to a comment that Lavanya made about innovation in a vacuum. So I was on the board briefly of a university-based innovation group. I won't name the university, I'm sure this problem happens everywhere. And they were very excited. The students and the faculty and the scholars had developed this technology. It was an improved cook stove. And then when they tested it in the field, it kind of cracked and broke under the sun. And I just wanted to ask this question, this fundamental question of what makes us in the global north think we can innovate for the global south? That's a question for anyone who would like to take it on.
I think we are sort of fortunate to live in this setting where we have access to sort of the latest and greatest in terms of technology. And also in terms of infrastructure, I think we have a lot more at our service. So I think it's probably, I wouldn't say easier, but maybe there are more opportunities to innovate here. But really, in our experience, what we've found is that what works here doesn't necessarily work in other settings, right? And there have been several examples of failed mHealth projects, actually, where people have taken platforms or other software that have been developed here and try to directly import those into resource-constrained settings. And one simple example, I worked with a project where we designed, or the group designed an application where they did something simple as, you swipe after every question on a data collection form, and the health workers hated it. And basically what they wanted was to have this sort of holistic view of the data, something that they were really familiar with, like the ones we saw in a register. And what the group ended up doing was to actually design an interface that looked like a register, but having the advantage of technology in terms of the analytics at the back end, where they could display on top of the register view, clients who are due for services and prioritize services and clients that way.
Which brings me to an expression that I hear a lot. In fact, I just recently read an interview with Melinda Gates, and she used it, which was, she called it human-centered design. Eric, you called it user-centered design in one of your slides. I'm just curious as to whether there are, what's the latest thinking and what are the innovations in human-centered, user-centered design? How do we do it and do it well?
Maybe I'll take that in following up with the last question. I get the spirit of the North-South division. In some ways, though, I think it's kind of a false choice because in the same way that I don't understand a rural Kenyan woman and her needs possibly for interacting with my system that we're hoping to develop, my developer in Nairobi also, who tends to be male in most cases, and is pretty far geographically and experientially from this person as well. So just basing your development in country, I don't think it's over that question. It's this idea of designing for users, and that's more of a process rather than a location. Even if you're not there, you have to be able to get data from people and to iterate on that. And I mentioned in my talk about being faster. We need to be able to come up with a product, get data, look at it, and put a new one out almost immediately and have a new test be done. Folks that develop for the web get this, and they have a very easy way of giving us multiple versions of websites that we go to. It's kind of the same idea, but we need to modify our approaches and our research strategies for being a little bit more nimble, I think.
I have a couple of examples. I'm not sure that you would precisely call it user-centered design, but FHI 360 and with grant from the Bill and Melinda Gates Foundation and now from USAID are working on two new different approaches to contraception that were driven by field requests in a way. One is a longer acting injectable. Women love, a lot of people are using injectable contraception globally, and in fact in parts of sub-Saharan Africa almost 2/3 of the method mix are injectables. And we've had feedback from the field that women and providers alike are interested in, gee, this is really great, but wish we didn't have to come back so often. So we're actually working on an injectable contraceptive based on that feedback that would last for about 6 months. Another thing that's been very challenging with implants is you can there's a large uptake, but then you have to deal with removals at the end of their effective lifespan, which is 3, 4, or 5 years, depending on the product. And so concerns about removal and access to removal has led to a grant to look at biodegradable implants, ones that could actually be inserted and removed for a defined period of time, because you don't want anything that's not, if it's going to be 1 or 2 years, you want to make sure that you can actually remove it, but at the same time, not have to remove it at the end. And that's a challenging task technologically from a formulation perspective, but we have 5 activities now that are collaborations with various investigators at universities and small pharma to look at that option. So again, it's maybe a little bit different than user-centered design, but it's using user feedback to define the next generation.
But one more question, it's for Nimi, and then I'm going to open it up to the audience. Nimi, we're sitting at a university. When it comes to innovation, there are intellectual property frameworks, licensing frameworks and agreements. We can't easily detonate those, but within those systems, are there ways in which we can still reach the poor? It's an easy one.
Can I get back to you with an answer? I'm actually working through this right now. So we've had our own challenges with respect to the tension between wanting to protect your IP, not because, my lab thinks that we're going to make a lot of money off of it, but simply because that's what the multinationals or the organizations that are going to take this to the next level want. I mean, the first question I get asked is, do you have IP and is your technology protected? Because it seems like that's what spurs competitiveness and gives someone an interest in taking this to the next level. And then, of course, when you look at some of the licensing fees for a technology, it is just sometimes so overwhelming that unless the technology is at a point where it's ready for prime time, very few people want to take a risk, which is why I was really excited by what I saw with the contraception is that, you might have the best intentions, but I'm seeing in my own projects that we have to almost sort of think about the end in mind and work backwards rather than trying to change the system, because there's inertia. You can't just change a system overnight, but what you can do is be as informed as possible. And if we want Philips or some major distributor that's in the countries where we want this to ultimately end up, we need to make sure we're talking to those individuals or organizations that have aligned interests. In other words, if we want to get to primary care, but they're interested in referral settings, then we're not really aligned. So I think it's finding people that are like-minded and that understand the processes and help us navigate that, because I don't see a simple way out of it by throwing our hands up in the air.
Questions from the audience? There are roving mics. Please let us know who you are, and if it's directed at anyone in particular or for the whole panel.
Yes, this is for Nimi. I'm Dr. Carrie Klett, and I'm an OBGYN, and many years ago in my residency, my research project was to use something called PAP plus speculoscopy. And it's the speculite, which uses a small chemoluminescent vial that is about 450 wavelength, or nanometers wavelength, and it was used on our very poor, not our poor patients, but our patients who would show up their first visit and then when they were delivering, who we knew were high risk for cervical cancer or precancer. So we could, at that time, initiate, we're doing the PAP plus speculoscopy with the acetic acid, and then also being able to do biopsies right at that moment and diagnose things, because in America we do have the luxury of getting the biopsy, sending it to a pathologist. My question is about, because this is fabulous, my patients hate colpos. So what, are you using the same wavelength as the colposcope uses, which is the green lights, or are you using the blue lights, or?
So, I don't know how much time I have to answer the question, but
30 seconds. Make it a haiku. Can you do it in a haiku? Can you do it in a haiku? No, I'm just kidding.
I need a drink. So very quickly to answer, we get grants for building, high-tech stuff. We went to Haiti after the earthquake with our high-tech stuff, and it turned out that many of the individuals that we worked with there, and actually Kathy Walmer is here, and I remember this was actually a collaboration with David and Kathy Walmer. My students came back and said that, we need to rethink simplicity is key. And so we want to essentially start from a point where people understand what's available and what has been documented as being useful, which is the colposcope. And what we want to do is really focus on making it patient-centric. Once we do that, we can add other things to that technology very easily, but we don't want to start with saying we've got something brand new when, it's important to start from a place that people are familiar with. And I would say that's part of the human-centered design, is going to these places and finding out that what we envision will solve the problem is not necessarily what people want to embrace. So it's white light, boring technology type of solution, but everywhere we go, there's excitement.
There's one there. Anne. Oh, sorry.
Hi. My name is Holly Burke. I'm from FHI 360, and thank you for the presentations. My question is about the immunization program, and could you please describe how it was integrated into the larger program, and then any plans for scale up? Could you describe those as well? Thank you.
Yeah, thank you for the question. So the program that we implemented was done in collaboration with the Ministry of Health and Family Welfare in Bangladesh, and we actually empowered frontline vaccinators who are part of the expanded program on immunization to actually use our system and collect data during the pilot phase. And we have data to now show that children and mothers who are registered in our system actually have higher odds of vaccination than those who are not. And so currently the idea is to integrate this vaccination system into a larger data collection platform that's being tested by the World Health Organization in collaboration with the ministry.
Thanks. I'm Ann Stars. I have a very, very broad scope question, which I hope is still productive. I was at, I think it was one of the Grand Challenges Symposia in Washington a couple of years ago, and somebody, I can't remember who it was, otherwise I would give him full attribution, talked about a framework for development of new technology, which was incredibly simple, but to me, in many ways, quite radical, which was you need to ask 4 basic questions. Is it needed? Meaning, is it filling a need, and that is there a gap because other technologies are not addressing that need? Will it work on just a practical sort of clinical trial level? And that's what most organizations and most companies focus on. But then the third step is, will it work on in a practical application? And you've already talked about some examples of technologies that haven't worked. And the fourth is, will people use it? And almost nobody pays attention to that one. So I would be interested in hearing your comments on this framework, and in particular where, maybe I'm wrong in thinking that the balance tends to be much more on those first 2 questions and much less on those, maybe a little bit on the third, but almost none on the fourth, and where you think how that balance could be changed or be made most appropriate.
I can start a little on the contraceptive side, but I will preface my comment by saying that I'm extremely biased. And my bias is around, will people use it? And I think that there, in terms of looking at new contraceptive options and thinking out of the box, sometimes it's really hard to think out of a box. We have this group of methods that have been around for 40 years, and then asking people what they want and how you ask them is really very challenging. But if you look at something like, I don't know how many in the room know about Mirena or Skyla, the levonorgestrel intrauterine systems, and it's a product that was actually developed with entirely public sector funding, with the goal that it would be available for under $10, and now it's $850 and very hard to access. But when you make it available, women love it. And yet, when you talk to people, and many providers and men, pardon me, but they don't get it. You know, they just really don't get this idea. So I think the idea of will people use it in the contraceptive space is really challenging to try to get at before an investment, but at the same time, I think we still do have to be thinking creatively and out of the box. And I'm not sure I answered your question there, but.
Eric.
Yeah. Oh, this is heavy. Just to follow up on that briefly, I had a guy who developed a product for detecting counterfeit drugs come in and speak to one of my seminar classes. And I said, how do you measure your success? He said, well, if it sells. Basically, if drug companies are using it. And I was trying to cover all the freshman years, like, wait a minute. We're talking about methods and validation. And he's like, well, if people buy it, it works. And I don't know if he's right or not, but I think there's something to it. There's a focus on people actually using it in real practice and showing that there's a demand for it. And I mentioned earlier about the need for more interdisciplinary teams, bringing people with that mindset. I think that's why some of my work hasn't worked out. We didn't figure out people need to use it, right? And that's an important metric.
2 minutes. I've got the 2-minute warning. Is there a really compelling, short, burning question that has to be asked and has to be answered?
I'm going to follow that.
There is. Oh, wow, the pressure is on. Sorry, I've really set this up badly.
Yeah, this is the most difficult question you'll ever have. You've talked a lot about, a little bit about community health workers and task shifting a little bit, Eric, and we've talked a lot about technology and how you make things simple. What I want to know really is, a lot of the attitudes that stop people using modern technology are what has to be changed. So what kind of a health worker are we talking about here who's going to go, into the community and make these things available? It kind of links to a previous question about the space between where we invent them and the people who use them. And who's making that bridge? And what sort of person should it be? Compelling or what?
That is brilliant. And from a Brit, I imagine.
From a Brit?
Yes. Extra marks.
We're coming back, guys. Better watch out.
Who'd like to take that one on? Or is it something we could talk about over lunch amongst ourselves?
There you go.
There you go. So that's a brilliant question. We'll come back to it, I think, this afternoon, which is a lovely segue. I'm going to use this captive audience to make 2 announcements. One, totally selfishly, next year we'll be launching a new centre, the Centre for Policy Impacting Global Health. It strikes me that the brain trust in this room is enormous, and I'll be hiring. So I'll be on the lookout for policy analysts, particularly those who have experience in development financing. If you've been at the bank or IMF or in a ministry, send me your CV. But more importantly, lunch, I believe, is served in the atrium. Please, during lunch, take a look at the student posters. And finally, please give this phenomenal audience a round of applause.
So we're going to start our afternoon session. Hope you enjoyed the morning and your lunch. So it's rare in one's life that one has an opportunity to introduce someone for me like Miriam Clayson. I'm particularly delighted. I don't want to embarrass her too much, but we met 31 years ago when I was privileged to recruit a young Swedish, I guess APO, I don't even remember what it stood for, Miriam, but I don't know if you did, something program officer, that the Swedish government was making available to WHO at the time. That program doesn't exist anymore. I was running a program in WHO, and I had a chance to meet Miriam, and it was clear to me this was a real potential leader in our field, and I was so happy that she was willing at the time to go to Ethiopia. She had been trained in medicine and worked for our diarrheal disease program at WHO for 3 years, and then Miriam came back and joined our team in Geneva. It has just been a great thrill for me to watch her professional trajectory and the immense contribution she's made to global health, particularly related to women and children, but not only related to women and children. Today, Miriam is the director of the Maternal, Newborn, and Child Health at the Bill and Melinda Gates Foundation, where she leads the foundation's work to ensure that mothers and babies survive pregnancy, childbirth, and the newborn period. I certainly don't have to introduce the Bill and Melinda Gates Foundation to this audience and all that it has done for global health. After leaving WHO, where Miriam was, I guess, there for 10 years maybe, working in diarrheal disease and management of childhood disease, she went off to work for the World Bank. She was regional program coordinator for AIDS, and we last met about 5 years ago, I think about 5 years ago, where in India, where Miriam was working hard to, I guess, shore up the AIDS program in the challenge of India. She has tremendous field experience. She's worked in many places of the world through all her jobs in Tanzania, Bangladesh, East Bhutan, Ethiopia. She's worked on health sector development programs in China, Egypt, Jordan, Nigeria, the Philippines, and Uzbekistan, and was even the World Bank team leader. I can just imagine what this was like for the National AIDS program in Afghanistan. I'm very grateful. Seattle's not around the corner, and I'm very grateful that Miriam has traveled here to be with us and eager to hear what she says. Her talk is titled Turning Evidence into Policy and Action, Saving Lives in Maternal and Newborn Health. And please join me in welcoming Marion to Duke. I didn't embarrass you too much.
No, you didn't. So now I'm going to embarrass you.
Now you're going to embarrass me.
Yes, I do want to embarrass Mike, especially for some of my younger colleagues here who are in the early phases of your career. With all due respect to Duke and academics, I must say what I learned in public health, I learned from working with Mike Merson as then the leader for diarrheal disease control. It was really working on a public health program. It was through Mike that I learned about what that means to work on public health program planning, being focused, target-oriented, the centrality of measurements, knowing what you're doing, what now quality improvement folks talk about, that loop between knowing what goes on in the field, feeding problems, using research to address those, and making a difference. That loop and the program that you set up really had an implementation arm and a research arm, and we worked very closely together. What you probably don't remember was that I came as a surgeon from East Bhutan and wanted to move into this world that you were in, and you said that you would send me to Nigeria. And I remember writing one page explaining why it would be better to send me to the Maldives. He didn't send me to the Maldives, even though I thought my justification was really strong. But he actually did say, we don't work in countries that have less than 300,000 people or something like that. So anyway, so I ended up 3 years in Ethiopia, and that was, I would say, the greatest learning that I've had. So thank you, Mike, for that kind introduction and for showing up here. And thanks for all of you to show up after lunch. While you digest lunch now, and before we move into these really cross-cutting, I would say at the edge topics of adolescence and mental health, two really, really critical topics for the future of public health, I will just pause a little bit and talk about some of the lessons from maternal and newborn child health field. What are some lessons we have learned from this particular niche around what it takes to move evidence into policy and programming? That process, as you all know, it doesn't end with the report, it doesn't end with the published Lancet piece, but how do you really transform, translate evidence into action? And I know so many of you are working in that field. So I will try to talk a little bit around mothers and newborns and the learnings that we have. We are, of course, right now at a very exciting juncture, and Gavin and others have alerted to that. My bosses, and I think you see one Duke alumni on that picture there, Bill and Melinda, the two of them made big bets at the beginning of this year. They said, we are going to make some big bets, and two of the big bets they made was that we can cut child mortality again by half, and that we could bring down the number of women who die in childbirth further, reducing that by 2/3 over the next 15 years. And of course, why they could be optimistic about this, even though those are very bold bets, was that the community that many of you participate in have made progress in the past 15 years. We have learned a lot of lessons, so if we take those to heart, we can indeed do very ambitious things over the next 15 years. And I would say, let's do it over the next 5 years. Let's not wait those 5,000 days towards the end of the 15-year period. So what happened last week, as you know, at the UN General Assembly was that these big bets and other big bets was actually made by all the country leaders of the developing world and the world, a strong commitment to a new set of goals, which for some are exciting because it brings all the critical determinants into the picture, but with the challenge that we then have to really make sure that we stay the course and that we really make a difference also in a world where we increasingly recognize all the critical determinants for change. So this is a very exciting time. And what happened 2 days ago was not just that there was this commitment to the SDGs, but there was also commitment to every woman, every child, which has a few targets. It has targets to bring down newborn deaths to 12 per 1,000, bring down child deaths to 25 per 1,000, bring down maternal deaths to 70 per 100,000. And I checked with Anne what the 75 was in the family planning field, and I understand it's bringing down bringing down unmet needs, so that 75% of women who wants to make a choice and plan family have access to contraception. So these are very, very bold, actually, because I would say that the low-hanging fruits have been picked in the first 15 years. Now we have to reach those that haven't been reached, and you all know that's much more difficult. The next 15 years will be about equity, rights, and our ability to reach those who are difficult to reach. For the child mortality target to be reached, the 6 million, you actually have to do something about newborn, right? Now half of the child deaths are due to newborn. That wasn't the case when Mike and I wrote a paper about what causes childhood deaths in 1991, I think, or something like that. Then really it was diarrheal diseases and pneumonia, and actually newborn was still a relatively small proportion. Now, as you know, it's 45% of all child deaths happen in newborns. 1 million kids die on their birthday. 1 million kids die on their birthday. And as you know, this is not for want of technologies. It's just for want of a focus, as someone alerted us to earlier, to quality of care. So the 3 million newborns deaths happened in some 10 countries. And that's bad news for those areas, but this means that we can be targeting our focus to India, Pakistan, to DRC, and Nigeria, and a few other countries which actually bear the biggest burden of newborn deaths. If we don't do anything, and we continue business as usual, this curve shows at the top where the trend is on newborn in actually Asia and Africa, and it will take us another decade. We will be into the century, I would say. It will take us more than 100 years to reach the same level of newborn survival in Africa as we currently have in the Western world. So there is a job to do to actually accelerate progress, and we can accelerate progress. So the first thing to do is really to look at who did well in the last 5-10 years, and what can we learn from countries who performed well relative to their income level. So not just the Rwandas of the world, but Malawi, Bangladesh, Nepal, other countries who against all odds brought down maternal mortality rates, and some of them also newborn. And you will see a trend here. Strong leadership, right? Strong leadership and political will that translates into domestic investments in health. And it's not just domestic investment, but in some countries it's really exploring, you take away user fees, ways to try to incentivize access to services. The third factor is really this, bringing simple life-saving interventions closer to the community. That really is a common feature of those who did well. They were early adopters of technologies, which some countries haven't yet even started to actually try to introduce. And some areas where WHO has not yet finished the global guidelines or policy documents on. Use of data is another interesting feature of some of those who have succeeded, is that they actually use data at subnational level, locally generated data, adapted evidence to inform policy, program design, and we have many great examples of that. What's also critical is those who have managed to do something about mothers and newborn did link communities with facilities. They did recognize that if you're going to save the mother and the newborn around birth, mothers have to come to facilities. But in many places where there hasn't been quality services, we have, of course, not seen a corresponding reduction in maternal mortality or newborn. Increase in care seeking, and where training is being done, as you know, good training, hands-on, skills-based training, and group problem solving are some of the features. Let's take a look. And what I will do now is just give you a few illustrative examples. I'm not going to do a systematic review, but I want to give you a few examples of how evidence has been generated into policy program, taking the case of Ethiopia and a particular intervention. Look at one example globally, how we in the foundation have rethought what we are doing in the maternal health space. And then look at two interventions that you would think would already be scaled up to full universal coverage, but which still are under 10% coverage, like kangaroo mother care, and why that is, and how can research help address those issues. So if you take Ethiopia, which prides itself of bringing down under-5 mortality rate ahead of time. Now, some of you who haven't taken equity lens on things will say, well, you know, there are parts of Ethiopia that still have pretty poor under-5 mortality rates, and that's absolutely the case. So we should know that when we talk about those who have succeeded, they have succeeded on an average to make great progress. But in fact, this is one of Ethiopia's current aim, is to try to target those that they missed in the first few years now. So how did Ethiopia succeed in bringing down so that 50% of lives are now saved from reduction in malnutrition, saved thanks to increased coverage of child immunization, oral rehydration? Well, they had a national health policy and comprehensive health sector development program. They had a health extension platform on which you could layer interventions. They thought about what that will cost and have actually increased its expenditure. And it also recognized that there are critical non-health factors, and some of you bring up the agriculture in the nutrition sector, etc. So Ethiopia is a very technocratic, you could say, Ministry of Health that appreciates technical innovations, think carefully about that, and translate that into policy. But it takes time, and that's what I think we need to think about. Those of you who create documents on which policy and programming is based, what does it take? For example, the journey from research to policy to action for newborn in Ethiopia. Take the case of the fact that 1/3 are infections, right? 1/3 are neonatal infections, as we show on that. Another third preterm complications, and another third interpartum events. The problem in Ethiopia until a few years back was that newborn infections were not treated by those frontline workers, were not treated out there at the community level. In fact, they were referred, and of course, if you refer a newborn with sepsis, you're either likely to lose that baby or who knows what happens to that, and that explains the high death rate. So the innovation or the solution to the problem was to integrate community-based management of possible serious infections into this health extension platform. And to do what we then did, a randomized control trial. So we took here, I hope you can read the fine print here, but we looked back in 2008, not we, others, maybe some of you, at the health practices, looked at what could be a good trial to try to introduce simplified injectable antibiotics at the community level in 2009, started a trial with some 640,000 people. And you see green circles, that's our investment. So here is the foundation putting major investment, others very little. What this resulted in was an increase from 10%, I'm reading because I'm not sure it comes out clearly, from 10% to 60% coverage of newborn with suspicion of sepsis that got antibiotics, translated into 15% reduction in newborn mortality. Now, how do you go from that? That's usually where our studies end, right? And we write our article and we stop. Well, the government of Ethiopia wanted to make this their national target and national mortality reduction goals. So they started work with UNICEF in 2011 to 2012 and other partners to actually do techno-advocacy, really making the case for scale. And the Federal Ministry of Health in 2013 announced a new newborn health policy, which allowed frontline workers to deliver these services. So in 2014, we had a national scale-up in Ethiopia to 13 million people that would be accessed by the services. And here you see a flip, right? Others are putting in money, we're putting in less. And that's our strategy. We want to be catalytic in the foundation, and we want others to pick up the bill. But if our money can leverage other funders, leverage other partners, that's, for us, an ideal model. So what's happening now is, of course, that this is going forward into quality of care, improving the quality services, bolster the system to provide the antibiotics that you need, and also looking at health practices. So this is the journey. It took 7 years and $16 million. But if we have to be explicit and serious about all these critical changes that we want to see and take research, a small innovation, to scale. And that's the example from Ethiopia. At global level, we have worked sort of on a linear hypothesis that, you invest in improved interactions between health workers and mothers that somehow translates this into mortality reduction. Lots of our investment went to the community level. And of course, as so many of you know, facility-based deliveries is increasing globally. And these are just a few curves or lines showing how national facility-based delivery trends play out from Malawi in the top, for the many women coming in above 70% delivering facilities. India rapidly increasing because of the insurance schemes that, encourage women to deliver. But also difficult areas, you see at the very bottom, Nigeria also increasing, and the difficult areas we work in, very rapid increase in Adamawa, very rapid increase in Bihar. So you cannot encourage women to go to delivering facilities and not improve the quality of that. And that's for us has been the biggest lesson. So that's why we are now increasing our focus on facility deliveries and working across the quality continuum, things that many of you here know much more about than I do. We're looking at all the dimensions of quality, right? Effectiveness, efficiency, time savings, patient-centered that we just discussed, user-centered approaches, safety. But in our investment, we also look across quality planning, the vertical here, quality control, and quality improvements. And I'll give a few examples of that. So we are doing things across from randomized control trials in this area, because you have to convince your donor partners, others, to actually invest seriously in this area. So that's why we have a randomized control trial on safe childbirth checklist with Atul Gawande, the Better Birth checklist. Even though many have already picked up the idea that a checklist is a good thing, we did checklist in diarrheal disease, decades ago. But we have to now show that works. And the interesting thing is it doesn't work on its own. It needs a mentor. So the biggest learning for India and the world from the Better Birth checklist is the checklist and a mentor is what's make a difference, right? So and the Indian government is very impatient. They want to scale up that nationally even before we've finished our randomized control trial. So that's such important learning going on right now. We do simulations using the Pronto. We saw an example of a doll here. The mentoring and coaching models, testing out different ways. Is it best nurse to nurse, doctor to nurse? What's the best constellation and how can you do that sustainably? We're looking at collaboratives, improvement collaboratives with DGHI here in, not just in Ghana, which is our big, success story, but also in Malawi, Ethiopia, and Bihar. And then, going back to some simple things that we did way back, baby-friendly hospitals. Can't we have mother baby-friendly hospitals? Couldn't we have respectful care and some accreditation based on actually treating a mother respectfully, doing the right thing, and then and having accreditation of facilities on the basis of that? So that's something we are exploring with WHO and UNICEF. UNICEF is leading on that. So here, ranging from randomized control trial, quality improvement testing, and adapting. It's a very exciting field, and I hope that we, 5 years from now, will be talking about the quality that's been really improved across facilities in poor income settings. Another thing we do, we look at efficacy, and we jump from product efficacy to program effectiveness without sometimes thinking carefully about what that means. And I want to bring up the case of antenatal corticosteroids, right? Even if you can't read all our list, we used, we looked at the additional lives saved that could be saved if you add to the baseline that you currently have. If we added coverage of all the 45 newborn interventions, newborn and maternal interventions that we have, what would yield us the greatest impact? And the only thing you need to know is that the gray shaded arrow on the left that goes across our table is family planning, which of course is a newborn intervention. The other big high impact best buy in newborn health is of course antenatal corticosteroids. 30 randomized control trials showing that it's efficacious in the Western world. And then there are things like newborn resuscitation, injectable antibiotics that I just mentioned, etc. We'll share this slide if you want to scrutinize it, but I want to talk about the antenatal corticosteroid story. So here we were, strong evidence, the best buy probably for preterm babies for the lung maturation, and very strong evidence. But then you have one study, right? And I'm sure some of you know it. I see some slides, some smiles here in the audience. You have one study which didn't actually look at all the parameters, just gave antenatal corticosteroids to be given by frontline workers without being part of a comprehensive approach, without actually knowing, am I giving it to a preterm baby? Because if you give antenatal corticosteroids to a full-term baby, the baby has more likelihood to actually die. It causes harm. So that study really threw us back and made us realize if we're going to push for something like antenatal corticosteroids in low-income settings, we have to know gestational age, right? And that, to me, is the biggest research challenge today. That's going to transform our field. If we actually know, and we can't rely on mothers, in a low-income city, it's very hard. Many of you have worked on ways to trying to find out how to do it. So the research that we are now supporting is trying to address key obstacles in the way from taking an efficacious, high-impact drug like antenatal corticosteroids to full scale so that you can bring down preterm babies' deaths due to preterm prematurity. So, because if you, as I said, antenatal corticosteroids that are just given, and if it's overprescribed and you don't know much about the mother's infections, you don't know quite how old that newborn baby is, causes problem, puts babies to risk. So we're working, of course, continue to work on training community healthcare workers to better assess gestational age and administer steroids. But most importantly, here is where you really cover the discovery end of things as well as the implementation research and the whole umbrella, looking at all sorts of ways that you could get a better handle on gestational age. I'm not going to list it to you because I don't want you to ask me questions about these because I don't know much. I know that we're looking at ultrasound to see if you could actually tell by the size of the cerebellum how the gestational age. I know we're working on preterm markers to see if that could get us to it. I know we're working and some are already using the foot size, as you know. We saw how well Uganda is doing. They're using the foot size. So here is a really, really exciting upstream field. I don't know if we're working with you who do cutting-edge, technologies, but this is what's really going to help us. This is the most exciting, and I can tell you, we are very impatient to see progress on gestational age so we can address preterm mortality with this. Now, here is an interesting challenge to all of us. Kangaroo mother care. Okay, kangaroo mother care has been around for 35 years. What's the coverage of kangaroo mother care? Except where you have some enthusiasts working in Guatemala and, you know, it's less than 10%. It's a few percent. And you know, kangaroo mother or kangaroo father care includes skin to skin, exclusive breastfeeding, and keeping your baby warm. That's a simple technology. It's not the fancy, some of the fancy technologies we heard about here. It's a simple technology. So this is how we are thinking about it. This curve has on its y-axis level of effort, level of focus, right? And on the x-axis, it's really ranging from fragile babies, you know, immediately after birth, preterm babies, and the left-hand side, to full-term healthy newborns on the right-hand side. We think we could broaden these wings, work here on the right-hand side. I hope it's, yes, your right-hand side. Why shouldn't kangaroo mother care be something good for all newborns? Why isn't skin-to-skin, exclusive breastfeeding the default position of any newborn? If that happened, then this normative change that some of you alerted to earlier today, this normative and the broader understanding in communities that this is the right thing, not just for weak little babies that die, but this is the best for any newborn that wants to survive and thrive. But that's not where we have positioned this. So how can we do that on the one hand? The other end of the spectrum is when do preemies die? They die in the first hour, right? First, second, third hours. When does kangaroo mother care sets in? After 6 hours. Why shouldn't we do kangaroo mother care immediately? Why not? And maybe even try resuscitation with the baby on the mother's chest. So this is where we are also doing work, and that requires, of course, working with sophisticated institutions. We work with the Karolinska Institute, because we say that's best also for Swedish babies. This is not low-tech for poor babies. This is what's best for Swedish babies. So that's why we're doing this research with Tanzania, Sweden, and some other institutions to say, hey, can we actually do this? Is it really a risk, or could we do this safely immediately at that? So that's how I think we could try to tackle some of these stubborn things, stubborn behaviors that don't change. Thinking about fragile babies and thinking about also fragile settings. Why shouldn't mothers now in refugee settings, the Syrian mothers, the Southern Sudan mothers, those who are working in really tough areas have access to kangaroo mother care? So how can we also work in fragile settings, not just with fragile babies in good settings, but in fragile settings? And as you all well know, that's where deaths are going to accumulate over the next 15 years, or in difficult settings, northeast Nigeria, where we work, in the areas where mothers do deliver in all these contexts. So how can we take a simple thing like kangaroo mother care and change the thinking? And if there are some who feel orthodox kangaroo mother care's protagonists who feel you can't call it KMC if you give it to all babies, well, let's call it something else. In East Asia and Southern Asia, Southeast Asia, they call it first embrace. We can call it something else. But if we spend 10 years talking about how we define it and how we label it, we won't move very fast. So now what will it take to make change? And I just want to reassure you that even we and the Bill and Melinda Gates Foundation do take a systems approach to this. If you have your goals here on the right-hand side, here are the goals: reduced to 70 per 100,000 maternal mortality, newborn mortality to less than 12. We have to focus on high-impact coverage rates, and some of you brought that up in the morning. That's wonderful. It's all about what drives mortality reduction. It's do a mother with complication get, it's not whether we sell products, it's whether the mother gets a uterotonic when she's bleeding. Does a mother whose blood pressure is checked 3 times at an antenatal clinic, does she get magnesium sulfate? We have to start to measure that, and we don't measure that. Think about it. In global public health, even today, we measure the number of contacts that families have. Antenatal ANC visits, we measure number of mothers who have access to a skilled birth attendant. We don't measure whether or not they get these services. So if we could do that, and then for newborn, we measure the number, of newborns who have a breathing problem that gets resuscitated, who gets dried, who gets exclusive breastfeeding. We're changing the whole way we're looking at newborn, maternal, newborn. We are starting to look at, do they get the services? Do we change the behaviors that causes a mortality reduction? That starts with healthy practices at home. They have to have access to platforms, antenatal, interpartum, postnatal. We have to have a few more efficacious, transformative tools. Let's continue to work on that. We have to have a primary healthcare system. And you know, that was the biggest breakthrough for some of us last week in New York, was that there was a big moment on primary healthcare. That's the way to go. That's the ways the SDGs will be achieved. Quality of care at the center of this, and then the evidence-based policies that create that enabling environment. This is our systems approach. And of course, data runs all through it. Some of you talked about things that I have at the bottom in gray. How do we improve household conditions? Things like, you know, the drivers, girls' education, wealth, gender, improve roads to get to the facility, the agriculture, other sectors. I hope that when we meet in 5 years from now, this is not in gray. It's upgraded as something we know how to do, and it's an integral part. But I have to tell you, we work in difficult places like northeast Nigeria, in the state of Gombe. This is their results framework. But of course, they say where 90% of women don't leave the household, then you have to do the things that's in the bottom boxes. So we're working on livelihoods, women's agents. We're looking at transportation for complications. Of course, you have to, in difficult areas, also look at some of these root causes and intervene at that area to make a difference. Moving forward to the end, using evidence to strengthen policy advocacy programming. You know, we have some great documents out there. We have a document on the essential interventions and commodities. We have a policy guide. But please, let's make sure we use this, because that's another. We might end at with our research and our dissemination of research finding might end up with a Lancet article, but some of it actually makes its way into some policy notes and guidance notes. You know, if we did more research around how these things, they're not trickle out, but how we explicitly translate and make sure these are core elements. For example, the Global Financing Facility everybody talks about today. We hope that the Global Financing Facility, which is meant for the first time ever to be a finance facility for RMNCHA and nutrition, that if you look at countries using a global financing facility to invest in RMNCH, that you have clarity on metrics, you have clarity on the core interventions that would be part of that. Which leads me to my final point. And that's a call for sustained and improved measurement in the SDG area. I'm so happy it came up in Gavin's and earlier discussions today. We call it the Kirkland principles. Why should everything be called the Bellagio or, you know, something else principle? This is a little suburb outside of Seattle. We brought together people who didn't have a vested interest in these things, but were interested in these kinds of things, to think about the fact, the poor state of affairs in MNCH metrics, the fact that we don't have everybody here or have agreement around the standard set of core indicators to measure neither quality in facilities nor household coverage, and said, how can we make a difference going forward? And these were the principles that our thoughtful thought partners came up with. First of all, of course, determine a core set of indicators. Right now, last time I asked the kangaroo mother care community, you know, what's the 2-3 indicators? They were still, you know, at 50 indicators, I think. And, you know, whoever you ask, it's just not doable. So friends, let's push for a few core indicators. That, of course, doesn't mean that persons in local contexts have their own set of indicators that make sense locally, but could we at least have a few core that enable us to measure progress? So that's one thing that should be localized. Relevance. MNCH coverage data should be of primary value in the country where the data is collected. Innovation, of course, we should think about how can we think innovatively about that? The things we are interested in, mothers can't remember that. Recall difficulties, right? A mother telling what happened during my pregnancy. Oh yes, I bled. Did you get uterotonies? No, this really requires us to do observational stuff in facilities. Can we think about how to extrapolate from facilities to households and actually get this data through new kinds of methods? And we're using some real-time observational things through our mentor and quality improvement work to see how we can gather real-time data around these factors. Equity, of course, should be now not something we need to actually discuss, but I'm sure we do. How do we have sound methods and tools to get coverage data that really gets at service quality, that gets at whether we reach those most in need, at highest risk. And we need, for this to move, we need leadership in countries. Countries saying, we need this data. So we think a lot about how, mechanisms that we've had today, like the countdown, how could we, regionalize countdown mechanisms to generate data and provide capacity building to local institutions to gather this kind of information? So that's what we call the principles that we are trying to see if we can make its way into all these various discussions on quality indicators and measurements. Because for you, or many of you are in the research field, also in research, wouldn't it be great to have agreement on standard, smart indicators that we all care about? Because what we want our research to aim towards is mortality reduction. That's this, for us, the filter. Is whatever you propose going to drive coverage that's going to drive mortality reduction? I do think we have some time for questions, so I will just stop here and open up for that. Thank you. So yes, we do have a maternal immunization, or mother's gifts to babies, which of course the biggest gift is that vaccine she gives through breastfeeding, right? But so you're absolutely right. What we feel is our duty in the maternal newborn community is to create the platform for that. So that if we get better at increasing the coverage of antenatal services, so that when these vaccines come, which I think will take a few years before we have sorted out some of these, we have the delivery platform. So then our colleagues who works in the pneumo and diarrhea field in the global health part of the foundation are really trying, as you say, to push the envelope here. Now that we know, for example, that flu vaccines can be given to pregnant women, it sort of opens up a huge new area. So I'm glad you mentioned that. Very important, future, exciting field.
My name's Jeff. I'm here at the Institute of Health Institute. As we see this growing increase in in-clinic births, then there's also the reality that in many of these markets, there's greater than 50% of home births, and they're often attended by traditional birth attendants, and there's a reticence to invest anymore in their training and so on. So one of the points of tension that I see is that if we try to provide safe delivery kits with chlorhexidine and misoprostol combined, you may find ministry folk who say, wait a minute, this is in opposition to our strategy of trying to have more in-clinic births. What's your sense of how we find a balance point that acknowledges so many home births, we want to make them safer, we want to save more newborns and mothers at birth, but we also want to support the movement toward in-clinic birth.
Thank you for that. And this is one of, the many dichotomies we create in public health, because of course what you want to support is the continuum that something has to be done, and you have to have someone in your community who can provide the service when the mother delivers at home, while she of course would encourage the mother to go to the facility. But I think you bring out an important trade-offs, and for me, and I think for many of us, it's not an either or. And how do we avoid that? There are so many of those tensions around in this field. So how do we encourage the continuum? And if you cannot bring a mother in to a quality birth, which is the case in so many cases, we do have to ask ourselves that very important question. So we think, for example, quite differently in parts of northeast Nigeria where women are born, do give birth at home, and we support that quality at birth at home, because we know they are not ready to bring in. There is nothing in the facility. So, but of course in India, where you have already a very strong financial incentives for women to go in, then we don't say go home, but instead, let's make sure that we provide the services that they need. And as you well know, if we do that right, then we can save both the mother and the baby. So the facility offers a great opportunity, but we shouldn't let the perfect be the enemy of the good. I agree with you.
Hi, I'm Maria Torres. I'm a PA graduate from Duke, and I thank you so much for all the work that you're doing. I'm working with an organization called 410 Bridge, and I have a program for maternal and infant health in Kenya. We're working with a Maasai up in Segera area, and we started a community health education, community health worker program just about a year ago, with great success. But one of the things that we just did last year when we took our team was have an open forum with the traditional birth attendants. And this was an incredible opportunity for dialogue. So instead of us coming and saying, this is the way you should do it, you definitely have to go to the birth facility. These tribes are very remote, and they have very little access to a clinical setting. So we brought emergency birthing kits and did open dialogue, educating the birth attendants, but also allowed a dialogue from them to us. And it was a very empowering experience. So we had, they were talking in Maasai dialect, we had translator to Swahili, then we had the English translation, but these women were so rich and beautiful, and their love for the women, and they were very open to what we were bringing, but it was done in a non-confrontational manner. So
I think both of you brought home the need to be contextual and appreciate the local conditions. What they've done in Ethiopia, where they also had lots of traditional birth attendants, were thinking about task shifting. So they gave them that role, for example, to give antibiotics to sepsis, while also giving them the role to go with the mothers in to deliver. So I think they are there, and they are an important part of society. And what can we best, how can they best be used? And if they're, if we put more emphasis for Maasai women to have a primary health care, we're not talking about tertiary, but somewhere nearby where they can get a quality birth, how can we make that transition and think about these trade-offs? So, yeah, thank you.
So, Miriam, let me thank you for everyone. We're so lucky that Bill and Melinda hired you. And that the foundation has such leadership, and I'm sure Miriam would be happy to talk with any of you before she leaves later today. Thank you so much.
Thank you so much. Thanks.
And I need the next panel to come
Yeah.
up. I think Miriam.
I'm introducing the new panel, yes.
Okay. Can we have the speakers just come on up?
While the speakers come up, I want to tell you the reason why I accepted the invitation to come here was the panel on mental health and adolescent health. I was so curious to know what your mental health expertise here at Duke are doing, because really mental health and adolescent health is, of course, the big neglected area. Mental health is so surrounded by stigma. We are using still very blunt instruments, both at the clinical level and at the level of understanding what's going on. So I actually accepted the invitation to come here because I wanted to be here and listen to you, the panelists here. And it's very exciting because I think we do have a full panel of all Duke faculty, and that's really nice. So I have the great privilege here to introduce this excellent panel that together, I understand, actually cover East Africa, South Africa, Pakistan, and the US in terms of the field where you're doing your research. And one thing I must confess that made me interested to come and learn from you was I was part of the Women and Health Commission, and it was shocking. The one statistics that shocked us all was the statistic that mental health, that is depression and harm reduction, is the #1 cause of death of girls and women from 15 to 25. It is now the major cause. Some would say, well, that's a problem of the Western world. No, this is the global data. So here we have the biggest cause of death, and I'm not talking just death and disability, but actually mortality, depression and harm. And still, as you know better than we'll learn from you, it's been a very tough thing to tackle, because it's not that people haven't known mental health is important, but that the question has always been, well, how do you translate that into practice? How can you integrate that into services? What is the simple algorithm? It's this quest for simplification in a complex area. So great welcome to the four of you. I think Joy Baumgartner, you will go first. And Joy is the Associate Director here for Evidence Lab at the Duke Global Health Institute, and she will actually share her research, her global mental health research focus on strategies for integrating mental health into various health services delivery platforms. And I think that's your title, Opportunities for Integrating Mental Health into Maternal Healthcare Platforms in Low-Resource Settings. I will later on follow with a question to you, Joy. What do you do when Mike sent me to Ethiopia, there was one psychiatrist in that country, and I think still today there are maybe 1 or 2 psychiatrists in countries where we work. So as we try to think about how we operationalize that, what do we do with the manpower challenge?
Hi, everybody. So I'm going to talk about specifically the bigger picture about global mental health and opportunities for integrating mental health into maternal and child health platforms, specifically in low-resource settings. And just to give you some background on the data, there are a lot of systematic reviews that are out there highlighting that the burden of perinatal depression, which includes both antenatal and postnatal depression, is high globally, but even higher in low and middle-income countries, where it's exacerbated by poverty, gender-based violence, unintended pregnancies, and lack of support. And depression causes both disability for the woman herself and her ability to cope with everyday stressors as she's dealing with a lot of familial responsibilities. And perinatal depression is linked to poor infant outcomes as well as socio-emotional and cognitive development problems in children. So by integrating maternal and mental health care, it can really influence MCH in general, and that's part of what I'm going to present in the bigger picture here. So the evidence is actually out there. It's been accumulating. People are synthesizing it. There's some really nice reviews that are out there, and now we're starting to see it in some policy guidelines and in some intervention guidelines at the global level. WHO's recommendations on postnatal care for maternal and newborn health in 2013, and within recommendation number 8, they do talk about, and this is their exact wording, at 10 to 14 days after birth, all women should be asked about resolution of mild transitory postpartum depression, whether they've been resolved, if symptoms persist, evaluated. It doesn't go into any more detail about that, but it's at least highlighting that mental health is in there somewhere, it should be assessed, and that there should be some sort of follow-up. Now, what to do for the follow-up? So WHO a few years ago came out with these really great guidelines. The MH-GAP Intervention Guide highlights what to do in low-resource settings for mental health services and disorders and non-specialized healthcare settings. So this is specifically for countries that don't have a ton of psychologists or psychiatrists available. What are some of the low-resource interventions that are possible? And in particular for depression, they really highlight psychosocial, although medication as indicated and available is also part of the guide. And it highlights just some basic psychoeducation, addressing current psychological stressors, which can include for many women in these contexts, domestic violence, reactivation of social networks, structured physical activity, and then follow-up and reassessment. So it's fairly simple, it's detailed, and it's really made for low-resource settings. So the opportunities, the actual physical opportunities for integration can happen at a facility level as well as a community level. At the facility level, you're starting to see these examples, usually small pilot or demonstration projects where you're screening for mental health problems, usually primarily depression, but also anxiety and somatic disorders, within antenatal care, PMTCT programs, HIV care and treatment, family planning, child immunization, like they starting, the whole MCH platform, everybody's starting to start screening for mental health, and then they refer. And then you don't know what happens after that. Then you've got the community level as well. And in Ethiopia, the Health Extension Worker Program is pretty amazing, but they're increasingly adding more and more services that they're asking the health extension workers to do. Mental health is actually a part of that. They're not all trained for it, but it is officially part of their package of what they're supposed to be offering for screening, and then they refer. Nigeria has another community-based program where they're trying to do screening and counseling and referral through church-based services. So there are a lot of new things that are happening at the pilot and demonstration level, and the most basic level, it's about the screening and the referral system. So integrating mental health requires more than just a screening and refer. You have to really look at the whole system, the whole health system, about how you can actually respond to this increased recognition of mental health problems at facilities and at a community-based level. And a big part of that is the referral system. So I have a project I'm collaborating with FHI 360. It's actually an extension of work that we've been doing there about facilitated referrals and using that to actually help strengthen mental health services. The project is related to depression and HIV and NCD services, but it can be applied, the facilitated referral model can be applied to integration of any sort of services that really looks at beyond screening, taking that opportunity for a little bit of minimal counseling, the referral, and there's a lot of different pieces that go into the referral, recording it, and then accompanying if possible, or escorting somebody to that next service, because the drop-off after referral is significant for every type of service across the health services system. And then once you've actually referred, making sure they get good access, monitoring the feedback loop. There's so many different elements that go into referrals. It's not just a quick, here's the next thing, and then hope it all works out for you. And so this is really spelling out, like if you're gonna add mental health to your program, looking at all the different pieces that have to go into making sure that that actually happens, instead of just saying, oh, I can screen and refer and I've added a whole new service, that it's much more complicated than that. So there's a lot of opportunity. Addressing maternal mental health can help women, children, and families. There are evidence-based and I would say promising, which are not quite evidence-based, but there's a lot of trials going on, especially NIMH is funding a lot of trials right now. So there will be even more interventions that people are going to want to scale up, and there are already some that are publicly available. I mentioned the WHO Intervention Guide. There's also the Thinking Healthy program, which you're going to hear a little bit more about, the Friendship Bench. They're coming up, and people can access them. They're becoming publicly available. The question is how to integrate them into your services so that it becomes part of a really comprehensive health service that you're able to offer. And I just wanted to sort of close that as we're advocating for more mental health, just really looking at it as a whole health systems perspective, and that you can actually embed that into the development and testing of your new interventions, not just as my new intervention work, but all the other pieces that go into that health service system. For example, the referral, the access, the monitoring, and the follow-up, having that all be part of what you're testing and developing. Thanks.
Thank you so much. I think we'll keep the questions for later. The next one I'm very pleased to introduce is Dr. Helen Egger. Helen is the chief of the Division of Child and Family Mental Health and Developmental Neuroscience here, and also the director for the Integrated Pediatric Mental Health Initiative and director of Duke's Early Childhood Mental Health Research Program. And I understand that you, as a child psychiatrist and epidemiologist, is engaged very much in both the developmental epidemiology and the developmental neuroscience. That combination, that's very exciting. And what you will share with us now is the work that you are doing to help us with early diagnosis of psychiatric and neurodevelopmental disorders. It's a mouthful here. Thank you.
Thank you. Great. Let's figure out. Okay, so I was really pleased in the earlier talk that you gave on measurement, because I'm actually going to be
laying out very briefly the problem, and then I'm going to show you some work that we're doing to develop new tools for measurement of early childhood mental health disorders and developmental disorders that really are trying to address these issues of access, the lack of providers, and also the need for evidence-based tools that can be used across development. And one of the things that we like to have called the work we're doing is seeing the unseen, because early childhood mental health is actually an area that's relatively new in our understanding. But this is from the work that I've done, as well as been replicated across a number of epidemiological studies, that like older children, young children, I'm focusing here on children 2 to 5, have the same rate of impairing mental health disorders as older children do and adults. The pattern of disorders is different, but the rate is the same, and it's 1 in 9. We also, oh, my slides are getting squished here, have seen a dramatic increase in autism, one example of a developmental disorder. Rate now is thought to be 1 in 68, and there have been global surveillances that have been done in terms of the rate of autism. So really addresses this question that mental health overall, but certainly with children, is a huge cause of disability. It's also about 30% of all disabilities. The cost is very, very high, but very few children, including children in the US, get any kind of evaluation or treatment. And this is here the child psychiatrist issue. This is showing how many child psychiatrists there are in the different regions. Red, it means that there's very, very few. But I'll tell you, in North Carolina, we have 100 counties. 70 counties do not have one child psychiatrist. So this is not just a program in low-resourced areas. Now, of course, child psychiatrists are just one member of a mental health team. Psychologists, social workers, nurses, PAs, that, you know, and pediatricians. So I don't want to sort of give the impression that this is only an issue of child psychiatrists. So let me just give you one statistic to think about the impact of the fact that kids don't get evaluated. So in the US, the mean age that a child is diagnosed with autism is 5.3 years. Now, we have the evidence we can diagnose autism at 18 months. So this gap of almost 4 years is a time when the brain is producing 700 synapses a second. It's one of the key times of brain architecture and growth. So when we think about the long-term impacts of our not intervening, they're huge. So the work that we've been doing has focused on early identification. We think that that is going to be the key for being able to intervene in meaningful ways in early childhood. And access to care starts with screening and diagnosis. And I'm not going to go into the details, but in terms of the barriers, we will never have enough clinicians to be able to meet the need. We will never be able to have the trainings and that kind of, you know, one-on-one training that is going to be necessary. The other thing is that the tools that we have now, and take the example of autism, the ADOS, which is a diagnostic observational assessment. To get trained in the ADOS in the US, it costs $2,500. You need to go somewhere to get trained or have enough money to bring the trainers to you. You have to go through a number of cases. And again, I just really want to emphasize in terms of access to screening, evaluation, and diagnosis, these are global issues that include our communities. So we have tools that are evidence-based, but we simply cannot use them. They're too time-consuming and they're too expensive. And, you know, the big thing is they just won't scale. So out of this, and a colleague of mine in the School of Engineering, Guillermo Sapiro, who's a computer engineer, came together to start the Information Child Mental Health Initiative at Duke. And what we're doing is trying to create a digital platform to be able to address the barriers that I talked about before. And we really think that computer vision algorithms, I'm going to show you some films and things, machine learning, and other methods of collecting and analyzing big data are really going to be how we're going to make a difference in this area.
So I'm not going to go through each of these, but I just want to say that from the beginning, Guillermo and I, and now our large team, came up with some guiding principles. And the key things here I'll say is, one, we need tools that can be used across development, but they need to be inexpensive or free, require minimal training. Here's one I think is important, non-intrusive to the child. Children with mental health problems or autism do not like to have sensors attached to them. And we have to be able to evaluate children in their homes, in their schools, in their preschools, in their playgrounds, where children live, rather than think of this as something that occurs in a doctor's office. So here I'm going to let this run. It shows an early example of the work. And this is a baby who's being evaluated for autism. It's blurred just because of confidentiality, sitting on the mom's lap. The examiner is holding an object and passing it from one hand to another hand. It's a test. Kids with autism take longer than 2 seconds to be able to track that moving of the object. And what's done now is that the examiner counts 1, 100, 2, 100. And with a GoPro camera that's just set up on the table, you see here that we have a much more refined measurement of where that child is looking. And just to emphasize, the little dots there, those are the child's eyes and ears, key features of the face. Those are automatically identified by the computer. And then the computer can measure, the algorithms can measure how this child is looking. So we're now, for example, doing a study in primary care using iPads, and we present stimuli to the children and then use the camera on the iPad or iPhone to record the child responding. So here's an example of how we can do automated analysis of emotional expressions, and this is a child, one of our postdoc children. So we are doing things to measure attention, head turning, response to name, pointing, joint attention, and emotional variation. So my time is up. Can I just show one cute video? Yes, I'll just show one cute video. So all right. So here's a little girl watching one of our videos, and this is here at Duke. And this is a typically developing child. And there's a lot of complex behavior in there, right? And then this is comparing a child with autism who's watching the same. And you see he's not really paying attention, he's not engaged by the narrative, and we don't get much of a response. And this is just the last thing to say. This is comparing coding of positive and neutral affect and social referencing by a computer on top and then a human. And you see that we are making progress and being able to create tools that can enable us to get our observational assessments out in the field. Thank you.
Thank you so much. Keep your questions. I'm sure there are many questions for you on this excellent presentation. So I'm happy to introduce the third speaker on the panel, Aisha Maselko, who is the assistant professor on psychiatry and behavioral change sciences and global health, and looks particularly at social and cultural factors and how that influences mental health. And I've looked at how school-age children have reacted to mothers who have had depression during the perinatal period. So very exciting work from both Pakistan and I believe also Sri Lanka. Please.
Good afternoon. Am I going in the right direction? Okay, great. So I wanted to talk to you a little bit today about the story of the Thinking Healthy program. And this is a perinatal depression intervention that's already been mentioned several times. So I thank the previous speaker for sort of setting this up for me. So that's a nice spot for me in the program. And basically the Thinking Healthy program was one of the first kind of, Oh, I see. This is how it happens. The piece of paper and it goes in the wrong place. Okay, great. So the Thinking Healthy program, it is an intervention, purely psychosocial, cognitive, behavioral therapy-based intervention delivered by community health workers. And I think the genius of the intervention is that it was made very simple. It is manualized. The manual is very simple to read. There's lots of pictures. You can see here the different components. So it talks about the relationship of the mother to the baby, talks a lot about the mom's nutrition. It talks a lot about the mom's relationship to others in the family. So this was a theme, I think, that came up earlier, is that even when we're talking about maternal health or maternal mental health, that we really are talking about the entire family, that we're not just treating this slice of symptoms. We're really bringing on board the entire family. And this was very explicit in the intervention from the beginning, which I think was part of its success. It's 16 sessions, and you can see it comes with sort of this kind of homework stuff. And this is a picture of the environment where, in Pakistan, where this took place, and pictures of training, and then some of the typical what it looks like in the household. So this was designed just over 10 years ago. And the reason why it's sort of become really well known is that it had these fantastic results. And so this was published in 2008. It was one of the first clinical trials that showed that a lay health worker could do an intervention, implement intervention with such a huge impact on maternal depression. So 12 months out, there's the depression rate in the intervention, half that in the control. So very nice evidence base that started coming up. And this generated a lot of excitement. And so it started being used by others in different countries. So, from sort of all over the world. And there was an earlier comment about, how do we know that something is going to work? How do you know that people are going to use it? And this was really taken up. And I think that one of the reasons why this particular team and why this particular intervention worked so well is that they spent a lot of time in the field talking to women and in the community. And also the entire team that developed it, they were people who were from Pakistan, who were educated both in Pakistan and then, in this case, in the UK. And I think especially in mental health, this really brings the case for us in a university setting about the importance of training of investigators from other countries who then can really bridge some of the potentially cross-cultural challenges. So I think that's one of the reasons why this was so successful. So the evidence started to build up over time, and then you heard a little bit about MH gaps. So this year, the Thinking Healthy program became an official part of the MH gap. So up to now, most of the MH gap sort of protocols for addressing mental health were sort of, as Joy Noel mentioned, kind of pharmaceutical treatments, and then kind of psychosocial education, dealing with stress, activating social supports and social networks. So then this kind of came online as the package, the official psychosocial treatment package. So really great success story, right? This is sort of what you want your intervention to end up as. Now this gets disseminated to all the ministries of health, and and there we are. But the thing is, this story, it's not finished yet. And so this is what I wanted to say, is that in a way, we don't ever stop thinking. There's no such thing as a great intervention that then you say, great, just do this 1,000,000 times over and everything will improve. There are some problems. There's things that if every Ministry of Health implemented the Thinking Healthy program, we would still have, or tried to implement, it wouldn't solve all the perinatal depression problems. So some of the things that are happening that now, and the team is very interested in addressing all of this. So that's the other thing, is I think you have to be really humble to acknowledge that there's things about your beloved program that doesn't work and that needs to be improved. So some of the things that that I think might not be unique to this particular intervention, which is why I wanted to mention them. The first is the fading of effects. So we actually were able to do a 7-year follow-up of that study. So, the really great gap between prevalence rates, depression, and control. 7 years out, it's all gone. It all completely faded. And so then started thinking, well, why is that? Well, you had these 16 sessions. The idea was that women were getting the tools to prevent the next episode. Depression is an episodic disorder. So now the team goes back to the drawing board and says, well, maybe we need to extend the duration of the intervention. Maybe they need boosters. What can we do? So kind of back to the drawing board, what can we do? And this is what is being, we're going to sort of try that out next. The second challenge, the human resource challenge, so this is something we've been talking about all day. One of the things that's being tried now is, well, can we take it even further, sort of, task sharing into integrating peers? Can we train women from the community that are not lady health workers? How do we adapt the intervention to make that happen? And that is currently that model is currently being evaluated by this large hub, both in Pakistan and in India. It's a big NIMH-funded study. And then another thing is this question of training and supervision. And so Eric earlier this morning talked about technology. So there is also sort of how can we use technology to reach places where we're not going to be able to maybe even get lady health workers, definitely not be able to train them. And so there's currently a pilot that's funded by Grand Challenges Canada that's to develop basically an app on an Android platform where you can do training videos and call in to people who are sort of health supervision and make videos and do the training material. And the thing that's being piloted is if you use this technology training, can you get the quality of, in this case, still the lady health workers to be the same as in the sort of full-on person training. So that is what is being currently done, is then, can we then take this out to, in the Pakistan setting, really wanting to take it into areas that are just a little too dangerous, that people aren't going to sort of go out there and do the training. So really, kind of the mountainous regions. And then the last thing here is integrating into MCH programs, and others have touched on that. And we don't quite yet have a really good plan for that. One of the things that happened is that the lady health workers, when we came back at the 7-year follow-up and asked the community health workers, did you like the program? What did you use? They said, we loved the program. We can't do it. It's too much. So, so how you can't integrate it if they wanted it, but they couldn't do it. So just to finish up, the work is not done yet, and hopefully this program will keep getting better and better. That's it. Thank you.